Good morning and welcome to the 2017 CDC OMHHE Office of Minority Health and Health Equity in collaboration with the National Center for Bioethics and Research in Healthcare at Tuskegee University's third annual Public Health Ethics Forum. This year's focus is on women's health, and the theme is optimal health for her whole life. My name is Shona Zollicoffer, and I will serve as the Mistress of Ceremonies for today. Today's forum is also streaming live, and for those attending virtually, please submit all questions and comments to owh@cdc.gov. We will have that slide back up for you. Again, that email is owh@cdc.gov. So today we have a very robust schedule, so let us get started. So allow me to introduce to you our first speakers, which are Doctors LaBird and Tucker. So Dr. Leandris LaBird is the Director of the Office of Minority Health and Health Equity here at Centers for Disease Control and Prevention. In this role, Dr. LaBird oversees the work of CDC's Office of Women's Health, Diversity and Inclusion Management, and Minority Health and Health Equity. She is a respected public health leader who has, over the course of her career, championed community health promotion, chronic disease prevention, community engagement, eliminating health disparities, and addressing the social determinants of health. She has worked in public health at the local, state, and federal levels and has held a variety of leadership positions at CDC since joining the agency in 1987. And our second speaker, Dr. Patty Tucker, is the director of the CDC's Office of Women's Health. Dr. Tucker's career spans from clinician for women and children to consultant on evidence and practice-based strategies designed to promote healthy lifestyles and disease prevention domestically and internationally. Dr. Tucker has worked with the Center for Infectious Diseases in Zambia, Namibia Ministry of Health, and Social Services National HIV Sentinel Serosurveillance Study of Pregnant Women, and in Sierra Leone to assist in the Ebola outbreak. So, to begin, Dr. LaBird.
Thank you, Shona, and good morning, everyone. Good morning to all of the early risers. We really appreciate your being here at 8 o'clock this morning. I know for some it was a sacrifice, but we were so excited about today. We just wanted to get started early, and we know that people will be leaving. It's Friday, they have flights and so forth, but I want to add my welcome to Shona's welcome to this year's Public Health Ethics Forum that is dedicated to the thoughtful and ethical consideration of a range of health issues that affect women and girls across the lifespan. Women make up just over half of the U.S. population, and they are present in every sector, at home. They are organizing communities, raising children and grandchildren, leading foundations, national and global organizations, and universities, and ensuring the implementation of sound public health policy and practice, among other things. This year's forum will delve deeply into selected public health issues that in some instances disproportionately impact women, and we will explore how we can be better at improving health outcomes for women and girls from preconception to old age. Today, you will hear from women and men, just a few, who are nationally recognized for their work as scholars, as practitioners, ethicists, and researchers. Our goal is to inspire lively and focused conversations about ethical issues we need to be aware of in order to deliver effective and inclusive public health programs that benefit women over the course of their entire lives. I want to take a minute of my time to thank all of our partners and the planning committee. I'd like to thank Dr. Reuben Warren, professor and director of the National Center for Bioethics and Research in Healthcare at Tuskegee University, for his commitment to the ethical practice of public health and the relationship that has been established between our respective programs. Many thanks also go to Joe Valentine and the Division of Sexually Transmitted Diseases for bringing us all together to expand the breadth of the cooperative agreement between Tuskegee University and CDC. I also want to offer congratulations on the 20th anniversary of the presidential apology for the Tuskegee syphilis study, and also to congratulate And I also want to congratulate the Division of STDs on the Public Health Ethics Internship Program. I'd like to thank Dr. Drew Barrett and the Public Health Ethics Office here at CDC, and Dr. Patty Tucker, Director of CDC's Office of Women's Health. And I'd like to thank and ask to stand this year's planning committee, Shona Zollicoffer, Gwen Baker, Laura Ross, Gwen is in the back, Dr. Joan Harrell, Benita Harris McBride, who is off celebrating the graduation of her son, and Jenny Kincaid. Where is Jenny? Thank you. There are also many others in the Office of Minority Health and Health Equity, in the Global Communication Center, and colleagues near and far who have made today's forum possible, and we extend our heartfelt gratitude to each of you. Susan B. Anthony, who is a well-known suffragist and abolitionist, once said, "Wherever women gather together, failure is impossible." So we begin the forum knowing that it is impossible for us to fail. Thank you so much for being here, for those of us who are joining us virtually, and I look forward to the remainder of the day. Thank you.
Good morning. It gives me great pleasure to extend to you a very warm welcome on behalf of CDC's Office of Women's Health. We are glad to have you here, coming from near and far, to attend the 2017 Public Health Ethics Forum. Sunday, May 14th, was Mother's Day, and that's the first day of the National Women's Health Week, which is celebrated through May 20th, through tomorrow. Since 1999, the U.S. Department of Health and Human Services Office of Women's Health has observed National Women's Health Week. During this time, women are encouraged to make their health a priority and to take steps to improve their health. This year, during National Women's Health Week, CDC's Office of Women's Health has coordinated the planning and the implementation of the Public Health Ethics Forum, Optimal Health for Her Whole Life. It is promoting and protecting from birth to older adulthood the health of women and girls. Optimal health is a state of a complete physical, mental, spiritual, and social well-being, and not just the absence of disease or illness. Optimal health for her whole life begins with comprehensive prenatal care for women in all communities, continual quality health care for all ages, promotion of individual characteristics and behaviors or environmental conditions that reduce the effects of stressful life events, financial literacy, attaining higher levels of education, economic security, ending the cycle of violence, preparing for retirement, and the list goes on. Here in the CDC Office of Women's Health, our goal is to support and protect the health and safety of women and girls by addressing health issues and identifying solutions. We hope today's forum is the beginning of a stimulating dialogue and opportunities to exchange ideas and views and create across multicultural collaborations. And through this exchange, ethical issues are identified and potential solutions or actions are put into practice for an impact on the well-being of women and girls across the nation. In closing, I hope that we all gain something of relevance from this day and time that we spend together at the 2017 Public Health Ethics Forum. Thank you.
Thank you, Dr. LaBerge and Dr. Tucker. So moving right along, our next speaker is Dr. Patricia Simone. Dr. Simone is Acting CDC Principal Deputy Director. Dr. Simone has served as Principal Deputy Director of the Center for Global Health and the Director of the Division of Public Health Systems and Workforce Development. There, she provided leadership in building ministries of health capacity internationally through the Field Epidemiology Training Program and the Sustainable Management Development Program. Dr. Simone is a retired captain of the United States Public Health Service Commission Corps. Please join me in welcoming Dr. Simone.
Good morning, everyone. I'd like to add my welcome to all of you to this forum today. I'm really happy to be here in my role as Acting Principal Deputy Director. I have had the great pleasure of getting to work with Dr. LaBerge and her team and learn a lot more about the activities of the office. And it sort of brings me back in early 2000s. I worked in the National Center for HIV and STD prevention before the hepatitis part was added. And I got to work with the Tuskegee program and the minority health programs there. So it's really great to be joined with this types of activities once again. I want to thank all of you for being here and thank the speakers that have come before me. So I have a few words for you today about CDC and this work. CDC has earned the reputation of being one of the most trusted federal agencies, and the way we're able to maintain the public's trust is by ensuring that we engage in high quality, scientifically sound, and ethical public health practice, surveillance, and research. Public health ethics is the process to clarify, prioritize, and justify possible course of action, of public health action. This process must be based on three things: ethical principles, the values and beliefs of the stakeholders, and on scientific information. While CDC excels at gathering scientific information, gathering is not enough. We must act on this information, guided by the principles of good public health practice. Dr. LaBerge talked to us today a little bit already about the work of the Division of STD prevention and the Tuskegee University. This collaboration is a really important one, and in 2015, part of that collaboration was starting these ethics fora. And these fora have highlighted public health issues related to African American health, Hispanic health data, and this year, women's health across the lifespan. These fora are an important way for us to come together as partners to advance health equity. CDC is committed to working with diverse populations and creating opportunities to better reach communities that may be underserved and whose voices often don't have a chance to hear. I'm also pleased to recognize the CDC's Office of Women's Health in coordinating today's forum. They are shining a light on the public health issues that in many instances disproportionately impact women and girls, who make up more than half of the nation's population. We already have excellent examples of this important work, and I'd like to mention two of those. First, heart disease. Heart disease kills 1 in 5 U.S. women. It's the American women's leading cause of death, and yet is often thought of as a man's disease. CDC's Wise Woman program aims not just to help women understand their risk of heart disease, but provides services to promote heart-healthy lifestyles. It targets low-income, underinsured, and uninsured women aged 40 to 64 years. It provides heart disease and stroke risk factor screenings and services that promote healthy behaviors. And this currently consists of 21 programs in 19 states and 2 tribal organizations, and is administered through CDC's Division of Heart Disease and Stroke Prevention. Another example is gynecological cancer. Each year, 89,000 US women are diagnosed with gynecological cancer. A teacher named Joanna Silver Gordon died in 2000 of ovarian cancer at age 58. She had all the symptoms, but did not recognize them for what they were. The Gynecological Cancer and Education Awareness Act is named Joanna's Law in her honor. To support Joanna's Law, the CDC, in collaboration with the HHS Office of Women's Health, developed the campaign Inside Knowledge, Get the Facts About Gynecological Cancer. This educates women and healthcare providers about the signs, symptoms, risk factors, and prevention strategies related to cervical, ovarian, uterine, vaginal, and vulvar cancers. And it encourages women to pay attention to their bodies and know what is normal for them so that they may recognize any persistent symptoms and seek appropriate and timely care. Programs like these are saving the lives of our mothers, our daughters, and our sisters. We are hopeful that today's Public Health Ethics Forum will result in the greater awareness of the ethical challenges associated with promoting and protecting women's health, the formation of new relationships among persons attending the forum, and a greater knowledge to inform all of our work to improve the health of women and girls. On behalf of the Acting Director of CDC, Dr. Ann Schuchat, and the senior leadership of CDC, we want to thank Dr. Warren and his colleagues at the National Center for Bioethics and Research in Healthcare at Tuskegee University, all of our guest speakers and facilitators and subject matter experts, the participating national centers, institutes, and offices, and all of you for taking time away from your other commitments to be part of this year's forum. Thank you very much.
Thank you, Dr. Simone. So next, we have a very lively speaker for you. I'm very excited to introduce, Dr. Reuben Warren. Dr. Warren is professor and director of the National Center for Bioethics and Research in Healthcare at Tuskegee University, as well as the adjunct professor of public health, medicine, and ethics, and director of the Institute for Faith, Health Leadership at the Interdenominational Theological Center here in Atlanta, Georgia. Prior to this, Dr. Warren served as Associate Director for Minority Health here at the Centers for Disease Control and Prevention. He also served as the Associate Director for Urban Affairs, as well as the Associate Director for Environmental Justice at the Agency for Toxic Substances and Disease Registry here at CDC. His extensive public health experience at community, state, local, national, and international levels range from clinical and research work in Lagos University Teaching Hospital in Lagos, Nigeria, to heading the Public Health Dentistry Program at the Mississippi State Department of Health. Please join me in welcoming Dr. Warren.
Good morning. A couple of don't do's. Don't stop by Starbucks and get tea or coffee because you may spill it on your coat and you won't be able to wear it when you introduce our speakers. I'm one of the few men that has the opportunity to speak with you today. And I am so very, very pleased and proud. One of the few men. I'm on the planning committee that worked to make this day possible. And our first meeting about when we decided to do women's health, I said very clearly, I will argue my point, but y'all make the decision. And in most instances, I argued my point, and they made the decision which was different than my point. It helped me to learn that I have a lens, but that lens is limited. So I want you to know your limited lens as well. It may be around race and ethnicity. It may be around gender and sex. It may be around income. And as I've learned being in Tuskegee, it may be around geographical locale. I grew up in inner city, South Central Los Angeles, urban America. Tuskegee is not urban America. I've learned a lot from being in Tuskegee. This forum is critically important from my perspective because it does a couple of things. It expands and continues an authentic, ethical relationship that has evolved into a true and authentic partnership. And there is a difference. And I'm intentional about using the word ethics because that's the basis of why we're here today. And it simply means doing not the right thing only, not doing things right as science drives that agenda, but doing those things through the lens of those who see it differently than you. And understand those who have the most to lose have the most to gain. And we ought to listen carefully to what they have to say. This forum started in 2015, as you've heard, because we reflected on 100 years since the death of Booker T. Washington, the founding principal and president of Tuskegee University, then Tuskegee Institute. Booker T. Washington had a lens that was not an unusual lens. It was one that looked at the whole picture, at all of us, and focused on those in greatest need at that time. And that sounds like public health to me. He found through the work of several of his colleagues, Monroe work, a statistician in particular, that the health of Black people was terribly, terribly different than that of others. And that difference was bad, very bad. He found that the causes, the preventable causes of death for African Americans were preventable, cost a lot of money, and cost a lot of lives. So he established in 1915 Negro Health Week. And what many didn't know, and we reminded them in 2015, that evolved into Minority Health Month, National Minority Health Month. So when you think you're starting something new, stop, look back, so that you can look forward. Negro Health Week is now Minority Health Month. Thank you, BTW. The lens of ethics has many spheres. And as many of us came through looking at understanding and trying to adhere to bioethics, a very, very important paradigm, evolved out of ethics, evolved out of philosophy, some would say. Others would argue evolved out of theology. But we won't argue that point. Where are we today? Public health ethics, a different kind of lens, one that we all think we know about because we all think we do the right thing. But it is a basis for how we should act in public health ethics, here and now. Not only the intention to do good, but doing good in and of itself. Not only honoring and respecting autonomy, but seriously engaging community. Not only in justice, but in social justice. And in my view, social justice and public health are one and the same. Doing things right, the importance of science. Doing the right things, the importance of ethics. Doing the right thing for all of us is the charge of public health ethics. So we're going to move on today in understanding that we all are vulnerable. Every last one of us has a vulnerability, whether you know it or not. But some of us are more vulnerable than others. I would argue those are those susceptible populations. Those who are most vulnerable are those who we should spend our greatest resource and most attention to. Know your vulnerability and look around, and you'll find somebody else with a different vulnerability. Help them, and in fact, they will help you. We're in this together, whether we like it or not. So when you win, I win. And quite frankly, when you lose, I lose. We're in this together. This forum particularly looks at women in their whole life, girls in their whole life. And every time I listen to my granddaughter, I learn something about women in their whole life. This is an exciting day, and I'm so very, very pleased to be here and to see that you're here. Thank you for being here, and we will have a good day. Thank you. I would like to present a friend and colleague. Because if you know anything about women's health, no matter how little you might know, to introduce our keynote speaker this morning to you would be an insult to you and, more importantly, to her. So I want you to take a moment this morning and listen. I've been in school for a long time, long time. I'm a slow learner, so I stayed there a long time. And I didn't learn much about listening. I learned a lot about talking, not listening. So I want you to listen this morning. Because in 1970, early 70s, while in Boston, I was teaching and talking, and somebody told me to listen. And as I did, I heard the name Vivian Penn. This physician at Tufts that was finding, motivating, inspiring, and guiding students, mostly medical students, mostly black students, but others, in Boston. And you know, in Boston, if you think you have something going, you take it to Boston. So I listened and heard the name Vivian Penn and how wonderfully she was doing with students. And when I joined CDC in the late 80s, 90s, I met some of those students who were here running CDC because they listened. In Boston, I listened and heard the name Vivian Penn. Years later, and I wandered around Howard University, and I heard the name again, Vivian Penn, because I was listening. I went there to talk, but I had to listen and heard the name Vivian Penn, chairing the Department of Pathology. Chairing the Department of Pathology, board certified pathologist. I was listening and heard wonderful things about leadership in and around Howard University School of Medicine. I was listening. I want you to listen this morning. And then as you heard, I worked a while here at CDC, and we were trying to work with all the federal agencies and everybody else who thought they had something to contribute. And I heard the word about the need for an Office of Women's Health. Heard it first here at CDC, and my response, because I was working in minority health, I said, well, women's health and minority health is different. So don't ask me to do it. I don't know how to do it. So I asked not to do it, and then there became an Office of Women's Health. And then as I listened and going through the agencies, I heard about a office or research on women's health and NIH. I said, no, who would have the courage and the nerve to do that? And as I listened, I heard the name again. You know what name that was? Vivian Penn. So everywhere I went and listened on strategies to improve the health of those most vulnerable, the susceptible, and I listened, I heard the name Vivian Penn. So when I decided to go down in the country, Tuskegee, I said, no, I won't hear that name. But then I said, well, I'm going to introduce Dr. Penn to Tuskegee. And I was embarrassed when she said, well, if I come, I need to stop by the graveyard to give my respects to some of my kinfolk. Down in the country, the name again, Vivian Penn. So I want you to be real intentional this morning about listening, not talking, but listening. And I'm sure you'll hear something you haven't heard before, and much that you have heard before, if you listen to Dr. Vivian Penn. Let's welcome her to the stage.
Got it. Thank you. All right. When she invited me to come into government, and thinking about giving up a tenured full professorship and a department chair in academic medicine to go to government, I said, no thank you, Dr. Healy, because I like to say what I think, and I don't think I'll last in government that way. I really literally said that to her. And her response was, she did too. Why didn't I come and try it? So in fact, that was how I started NIH. So I'm pleased to be here and pleased to be able to, with what time I haven't lost already screwing up this presentation, but to be able to talk about the topic, which is optimal health for her whole life, which to me is really referring to lifespan issues. And I often think when we talk about women's health, the label we gave, and over the years, really thought we really misnamed this because we really should have called it the health of girls and women to really reflect that lifespan issue instead of just women's health. But that's all right. We'll make up for that as we talk about the continuum health. And this is very timely because it is National Women's Health Week. So from the standpoint of, I know the perspective of the Bioethics Center, and for those of you in the room looking in the terminology and relative to ethics, justice, and inclusivity, that National Women's Health Week is a wonderful time, right on topic, to look at the issues related to women's health or the health of girls and women. Now, I can say, and I'm sure there are many in this room who've been involved in women's health for many years, and Marcia, I'm going to call on you in a minute, but I'll get to you in a little bit. That's Marcia Henderson, who is the director of the Office of Women's Health at the Food and Drug Administration. Before that, held many positions and has been with that office for many years and has really been a wonderful colleague. I probably now don't get her in trouble since I've been retired for 6 years, so she's on her own and she can behave without me stirring her on, but has been a great champion. If you don't know Marcia, stand up, Marcia, so they will know who you are. But many in this room I know have, and we are well aware that how we define and what we think about women's health, how women's health or the health of girls and women really has changed since the late 1980s, and especially since about 1990. And that came about because of advocacy combined with scientific, legislative, public policy, and human rights considerations. And it really is important to reflect on that because it shows that when you have concerns, that actually it was grassroots efforts that led to eventually a change in public law for this country. And so we can bring about change if one is dedicated enough to what we are trying or one is concerned about. So what was the historical view? We talk a lot about the traditional view of women's health. And actually, because I didn't want to have 100 slides, didn't put them in, but there are textbooks and there are many documents from the 80s and 90s. And I go back and look. I finished medical school, I hate to say it, but I finished medical school in the 60s. And looking at the textbooks that we used at that time, and women's health was defined really in terms of reproductive health. Women's well-being was defined in terms of her sexuality. And women's health was really considered to be the reproductive system during the reproductive years. If you ask what was men's health, it was the total body system, everything from head to toe, all of the systems. You asked what was women's health, they send you to the OBGYN because it had to do with reproductive health, with pregnancy. Almost nothing related to women's health after menopause. It was as though once you hit menopause, reproductive years are over. You just sat in a rocking chair on the front porch and you rocked, and that was it until you passed away, as opposed to looking at healthy aging, et cetera. So I think Marianne Legato, many people have claimed it, but as I look back, I think it was Marianne Legato who first gave the label bikini view of women's health to that idea. Well, we've made some changes, and one of the first things that we had to do at NIH when we began to study women's health and to really look at it from the standpoint of research, which is very important, is two things. One, to recognize that women are not the same as men, because this whole concept of attention to women's health really came about because of the concerns of whether or not standards of medical practice were being based on information that came from the study of women, or whether studies of health issues in men, aside from reproductive issues, done in men were being applied to women as though women were just little men. And obviously that's given rise to the whole field of sex and gender-based medicine and policy, if you will. But also recognizing that women's health didn't begin at puberty and end at menopause, but that it really encompasses the entire lifespan. And so we had two things to do. One, to bring up the concept of comparing women with men, and secondly, to look at the expanded concepts of women's health, and not just from birth to grave, which is what some like to refer to. But as we talked about sex and gender differences, and obviously based upon many of the things I had been involved in and the fact that I was heading this office, we could not just look at women in terms of the fact that women are not just like men, but the fact also that not all women are the same, that there are differences between different populations of women. And it may not have been popular in 1991, but one of the first things our office did was to declare that as we look at women's health, there would be two aspects. One, to look for differences between males and females, and secondly, to look for those factors that contribute to differences among different populations of women or different populations of men, which to me is a way to explain why there are health inequalities, why there are health disparities, and looking at those factors across the lifespan, if you will, not just in terms of health status, but health outcomes. How do we respond differently in response to interventions, in responses to the environment in which we live, which we're born, in which we grow up? How do we respond different to treatments? And that really, this slide really kind of summarizes the essence of what I really worked for and how I constructed programs during the 20-plus years I was at the Office of Research on Women's Health at NIH. If you didn't know, Dr. Warren didn't tell you, I'm supposedly retired in 2 months as of 6 years, and you would not know it from my schedule. But anyway, I am supposedly retired, and I have flunked retirement, but that's another story. But looking at health disparities and health inequalities, and I must say that CDC has a lot of wonderful information, really coming out of the Office of Minority Health and the other and other parts of CDC, with good literature and good explanation about health disparities and health inequalities, which I often quote when I'm speaking about health disparities. But we all know what health disparities are. But I had this slide that I often use, but I added the section, gender equity is a social determinant of health, because as we talk about those factors that contribute to health and that contribute to health disparities, I just on, Wednesday, 2 days ago, I can't keep up, was at the NIH, where they have a lectureship for women's health. And it was interesting because one of the speakers made a big point of looking at social determinants of health and emphasizing that gender equity is a social determinant of health. And I think I've been implying that, but I like the way she emphasized it, so I added that to my slide to make that point, because we know that the Center for Bioethics is focused on and wants us to consider social justice and social justice, and to me that brings that forward. And as we look at what's happening in terms of looking at different populations of women, we know that there are differences in health status, health outcomes, access to care, and that term which we need to now reframe in the current socio-political environment, really differences, and that if we're going to make a difference and overcome these differences, we need to know what we need to overcome. Anecdotes don't work. To me, that is the value of research, that we have the evidence so that we know what we need to tackle, what are leading to, what is resulting in these health disparities at different points of the lives of women and different populations of women. Excuse me. So, when I went to NIH, and many asked, why did you leave academic medicine to go to NIH and become a Fedocrat, if you will? It was because, having been out there, like with Dr. Warren and many venues we'd been in, knowing we were trying to make a difference in what was happening for health of our people and our communities, as well as people in general, knowing that anecdotes were not working, that we really need to have the information base, and the fact that there now was going to be an office that would be focusing specifically on getting the data, and what we have is an evidence-based system of medicine. And in order to change standards of health practice, in order to change what is taught in health profession schools, in order to change what women and their families are told about preserving their health, we don't need stories that are carried over. We need evidence, we need information. So research is important. And having that information from research, then having that information incorporated into healthcare as well as into public policy, can then help us to change and require changes in standards of healthcare delivery, as well as know what to inform women and men and their families about what they can do to preserve their own health. So I mentioned this, and I'm not giving a lecture on inclusion, but it's important because this is what came about. And actually, I have to give a lot of credit to Dr. Warren, because the Center at Tuskegee has really focused so much over the years and continues to on the importance of inclusion in clinical research of women and minorities in generating results, and actually has had a number of symposia dealing on the issues of inclusion. And I think well, Anita, I know that you're working on a project on that now, but I wanted to just emphasize this. If you think about it, actually the actual change came about out of the women's health movement, because it was the women's health movement that actually went to Congress and said, NIH is not including women in clinical studies, we need to make sure they're going to do that. And a policy for the inclusion of women was developed. But then there were some who said, well, what about minorities, which was the terminology used then. And so then the NIH guide said, well, let's add the word urging. So after inclusion, then there was a language was added that said we encourage the inclusion of minorities in clinical research at the NIH. And then the General Accounting Office, at the request of Congress, looked to see whether NIH was following these guidelines and were women and minorities being included. Focus was primarily on women, but it also looked at whether or not women were being included. And it was actually NHLBI, the National Heart, Lung, and Blood Institute, that seemed to be doing the best at that time in 1990 in ensuring that that members of minority communities were being studied. But when that report came out saying NIH was not doing it, it was a press conference held on NIH's campus to lambaste NIH for not making sure that women were included in clinical studies, that led to the then acting director of NIH to announce, we're setting up an office to make sure this happens. And that was what the genesis was for the Office of Research on Women's Health. It really was established to respond to concerns about the inclusion of women. You can't separate women and minorities, and although there was an Office of Minority Health Programs at that time, you can't separate and have two different sets of data. So actually, we ended up doing primarily looking at most of the issues related to inclusion of both women and minorities. And as I think you all should know, in 1993, what had been public policy became a matter of public law. And as far as I know, we're the only country in the world that has a public law that requires in federally funded research that women and minorities be included in clinical studies. So that is sort of the genesis of what came about. And actually, in presenting this, when the law was passed, it really just strengthened the policies NIH had. This was in the NIH Revitalization Act. FDA has since had language directing it to look at reporting. Remember, FDA does not fund research. It is a regulatory body, so it doesn't fund research. At NIH, we could say, you won't get the funds to do your research if you don't meet our policies and requirements, while FDA has to evaluate research that's done independently and is brought to it. So it's a little bit different. But we were so proud that we were able to show that we were beginning to include women and minorities in clinical studies. And then I began to get letters from members of Congress, mostly male members, saying, NIH is discriminating against men because all the data is looking at women and minorities in clinical studies. So I learned that when I talked about this, I had to automatically just cover myself by saying that we assume, and the basic assumption is that men are being included in clinical studies, and the purpose of our efforts are to make sure also that women and members of minority groups are also included in these policies. The purpose being really to get back to the concept of ethics and justice, to make sure that the results of research are applicable to all segments of the population. Remember, prior to this effort to move into inclusion, and one of the major areas that we've all had to deal with is that for years, women were not included. And one of the reasons, one of many reasons, but the major reason used to justify that was that women were vulnerable. It was going to hurt them to be in, and there were going to be problems. And the same with the reference to the PHS study at Tuskegee, that maybe we shouldn't have African Americans in clinical studies because we should be protecting them. We should not be using prisoners because 5 minutes and I'm through. Oh, wow. Well, maybe I should just stop now. Let me see here. In any case, let me see what I can do because I'm just getting into this. But it's a matter of looking at inclusion. It is a matter of ethics and justice. All right, 7 minutes. I'll see what I can do. And so we look at and think about these principles of justice and equity, that they really need to be considered in the multiplicity of factors that contribute to or prevent good health and wellness in girls and women across the life continuum. And being able to not just have access to health care, which is what we've been referring to and always refer to, that we get the results from research, we know what state-of-the-art art of healthcare is, and we want to make sure that women and minorities have access to that healthcare. But in the current political environment, we're learning that we can no longer just talk about access to healthcare, because we're learning that that word can be used differently. Having access and actually being able to take advantage of that access is a new way of looking at that terminology. So we all are going to have to think differently about how we express that. And so out of this, I've now moved into a new terminology, and I think this is going to probably be at the basis of most of my talks about health and healthcare now, that we really have to think about the socio-political aspects. Now, I am retired from government, but I still have a government title, and I'm in a government building. I'm not being political, but if we want to think about contributors to healthcare, we have to think, and health status, we have to think about those sociopolitical aspects. And if you're familiar with that report that came out about differences in health and mortality in different counties across the U.S., I just heard a presentation on Wednesday looking at that, and that one of the major contributors to differences are state policies. And as we look at the discussion now about what's happening in terms of health care and perhaps a new health care bill, and whether the states will be controlling or national standards, we need to be concerned about those socio-political aspects. All right, let me see what I can do in 3 minutes, even with the Southern accent. Ruben, let me see what I can get through here very quickly. We've always talked about the many contributors to differences in health status, and I think women's health was one of the first areas to go beyond just the biological factors that contribute to women's health. You cannot look at women's health and think about women, and perhaps this should have been true for men, but at least we did this for women, and hopefully the men's health area learned from this too, that we can't just think of it in terms of genes and biology and environment, but we need to think of all of those other factors. And we really began looking at social determinants of health. This is not my diagram, but it's a wonderful diagram that I've adapted and used from that article by Dahlgren and Whitehead. But if you think about it, we really started looking at social determinants of health before there was an Office of Biobehavioral and Social Science Research, before there was emphasis on that. And so when we look at factors related to the health of women and girls across the lifespan, we do focus on, and we have to continue to focus on, and especially in today's environment, behavioral and social or societal factors, as well as looking at race and culture, how women relate to their bodies, environmental exposures, not just looking at endocrine disruptors in the soil, but also looking at things like access to toxic waste that may be in an area, or where one lives, with how far you are if you're in a rural area from having access to a physician or a nurse or a clinic, and also looking at that access to medical practice, or I should say healthcare practice. And of course, looking at life course, we've seen many different variations or divisions of life, of the periods of life, of course, the lifespan. And mostly it boils down to prenatal infancy and childhood years and adolescent years, reproductive middle years, pregnancy years, menopausal transition years, and the elderly, frail elderly, and healthy aging years, to sort of separate those who are healthy elderly and those who are elderly but frail, because there's sort of a difference there in terms of looking at health and health divisions. But the important point is that it's really a continuum of life. It's not that you jump from one to the next. And it's like people, when you see references often referring to women under 50 and over 50, we know that age 50 is arbitrary because it's used to sort of suggest premenopausal and postmenopausal, assuming that age 50 is the stand-in or the surrogate for menopause. And yet we know some women undergo menopause at a much earlier age, some women undergo menopause at a much later age, so you can't assume that once you're 51, you're automatically fitting in all the data related to women at age 50 and over or under. So we really need to think of our life course as a continuum, and that's what makes the lifespan or life course important. And actually, when we think about it, and with that in mind, we really, and one of the most important things to come out of not just women's health research, but I think out of science, are those concepts to help us recognize that there are contributing factors, not just from birth to death, but actually from pre-birth, meaning the intrauterine environment that can affect our health as we become adults and as we age. And so we really need to think about that comprehensive continuum from the intrauterine environment. I like this slide, which came out of our strategic plan that we did, that really is sort of based on the Barker theory. That is, that if you look at conditions or statuses, even things like substance abuse occurring in adult years or later years, that often it can be tracked back to influences in the in utero time. And so that Barker theory, we actually spent a lot of time funding research in that. Don't hear as much about it, but it's beginning to come about again. But it really comes down to the idea of looking at the importance of the in utero environment for healthy babies and for healthy adults, really with that spectrum, which is why I have a great time not understanding the objections for providing maternal care, but that's another issue. But actually thinking that if you provide, whether you're male or female, and you're helping to support maternity care, maternal health care, that you're actually looking out for both men and women in their later years because of the effects a lack of prenatal care can have on the health of the fetus and therefore the health of who's going to be the adult male or adult female 30, 40, 50 years later. That is important. And so we can look at the health factors, keeping in mind it's a continuum for prenatal, infancy, and childhood years, really looking, mostly focusing on the implications of the in utero environment and prenatal exposures. We don't see a lot of sex differences and a lot of difference other than low birth weight babies and mortality and maternal mortality in those early years. But getting into adolescent years, which is where bad behaviors seem to begin to form, you have to worry about sexual maturity and what's happening with STDs and handling the sexuality, looking at eating disorders, obesity as it comes, or the other extreme, the eating disorders. Yes, teens are beginning to experience intimate partner violence, even in the adolescent years. We're seeing issues related to drugs of choice, but I'll get to that again in a few minutes. But looking at the teenagers with their parents' prescriptions out of their bathrooms for substance abuse because it's quote unquote a fun thing to do. But we know that 7 out of 10 deaths for kids in this age group are related to unintentional deaths like motor vehicle accidents, homicide, and suicide. So these are things that need to be considered in that age group as we but then also, how good are we at delivering health care? Do teenagers, do adolescents, do they go to the pediatrician? Do they go to the gynecologist? Do they go to the general internist? Do they go to the family practitioner? Or do they go to their friend next door and ask, what do I do? And go to their buddies in the local gang or local group. So we really need to give more attention to health care, health direction, and health information, because we do know that teens can carry out some wonderful ideas and work and help improve the health of their parents when they're in on it. And then looking at reproductive and middle years, we talk about going beyond the reproductive system, but there is so much more we need to know about the reproductive system, so we can't forget that. There are reproductive health issues. And again, it is important to have healthy pregnancies, full-term babies, and that continues to be important in addition to fertility issues as well as fertility issues and reproductive health and things like fibroids and endometriosis. But then really looking at obesity, and we know how obesity affects, we look at healthy behaviors. Intimate partner violence really becomes an issue here. Cardiovascular disease, and you've already had, I'm not doing a list of all the diseases because I'd spend all day doing that, and you're familiar with them, but just pointing out so many issues that are a major concern during this particular part of the lifespan continuum. And of course, cancers, especially at this age, breast and cervical melanoma. Now, with the idea, and it seems that every place I've been recently, and I've been too many places recently, but almost every place I've been, I was in Boston just a few days ago, and then again this week at several meetings, there have been discussions about overdose, opioid abuse, and I know you have discussion session coming up, but you heard my background is pathology, so I recently had visited the DC morgue, and the chief medical examiner there is a great young man, Roger Mitchell, who is now in charge of that office, but he was telling me about the increase that they're seeing right in DC. So I just wanted to see how how the data there really would look when put in terms of national data, which you'll be hearing about. But it's interesting because you can see that the major increase in drug use and drug overdose use is among age 50 to 59, and so not in the teenage, but the later years. Actually, women constitute only about 25% in DC of those who die from drug overdoses, but it's interesting to see and it's nice to see that women went down a little bit last year. But look at the variations by race and ethnicity, and this is the kind of data I want to see. And just look at blacks, for example. Now the red line for 2017 this year is only 5 months underway, so we don't have much data yet. We hope it won't catch up. But look at the difference between 2014 and 2016 in the number of opioid deaths. And of course, they're mainly opioids, fentanyl, et cetera, and derivatives, et cetera. So while these fatal overdoses are more common for males and females, we still have the issues of women who about 25% are women. But then beyond that, when we lose the young men or the older men, the impact on the women of the family in caregiving and taking care of the family, and the impact, so women are affected. Menopausal transition, if I could take off my jacket and show you my back, I could show you lots of scars related to the fact that I was the co-director of the Women's Health Initiative, which you may or may not recall was a study that looked at, it's a broad study, and CDC was actually very involved in the public health studies of that. But the major thing the Women's Health Initiative was known for was of the stopping of the study early with recommendations that menopausal hormone therapy should not be used for prevention of cardiovascular disease or prevention of other diseases, and that there were more risks than benefits. And my back still itches from the attacks I got from that. Well, that was 2002, and it's continued on. I just want to show you that for the menopause areas, the menopausal transition, the major concerns continue to be around the use of hormone therapy. And I want to show you that the Preventive Services Task Force just came out this week with putting out again recommendations, which essentially say what, in fact, Marcia Henderson can tell you, because the FDA actually gives the direction. The FDA has never approved the use of hormone therapy in menopause for the prevention of chronic diseases, although that's what most physicians used it for and what most women thought they were taking it for, prevention of chronic diseases and to keep them young and sexy, which is what we were sold through our traditional. Don't let me get started on that. In any case, I want you to know that this is again coming up. This is just this week, but actually what they're recommending is something that, because actually Marcia and her office are really responsible for the education of women about this topic. So I just wanted to show you that. And then looking at elderly and frail elderly years, and I was watching the clock. I started at 5 minutes afterwards, so I think I have another 5 minutes. Is that okay? All right. Thank you. Because you really called me off for 5 minutes and it was 15 minutes. But anyway, sorry, I'm watching. But looking at the elderly and frail elderly years, and that's when we get into issues like osteoporosis, as well as cancers. Again, we know the greatest risk for getting breast cancer is being a woman and getting older. And then looking at the fact that the new data shows that opioid and drug deaths are increasing in older years. But we can summarize all that by saying that when one gets older, especially for women, but it's true for men too, but especially for women, we live longer, but we're more apt to have complex chronic diseases. We don't have just one condition. We often have an interaction of chronic diseases, and that can be a major issue for healthcare. So when we think about interventions for health disparities for women of color or women in general from midlife to beyond, we want to lessen disparities. We want to prolong life. We want to preserve mental acuity. We want to prevent functional physical decline. We want to be able to get around, be mobile, not have to go to a nursing home because of incontinence or not being able to have have free mobility ourselves and continued, I shouldn't say improved, but continued good quality of life. And I just want to mention briefly a major area, and I know that it's interesting if you go to your college reunion or school reunions and you see the differences as you age along that continuum. I remember when I went, and where is Rochelle, who's also a Wellesley grad? I remember many years ago I went and everybody was talking about menopause because the class was getting to that stage where everybody was going through menopause. And of course, then I had all the answers, I thought, from the Women's Health Initiative. Then the next one, everybody was talking about dementia because so many people in the class were affected by taking care of parents or relatives with dementia, their in-laws or their own parents. And that was a discussion. I don't know what it's going to be when I go back for my 55th reunion next month, but well, I can imagine. But anyway, but knowing that dementia is a major problem, and we do know Alzheimer's is more common in women, not just because we live longer, but now it's been shown it really is more common in women, even with or in spite of living longer. And so we look at attention to dementia, and that not just Alzheimer's, but other forms of dementia and how important it is. But it then raises another area because important for women's health, actually looking at what if some refer to as the sandwich generation, for those who are midlife, who are taking care of older parents as well as younger, their grandkids, but then also looking at the fact that for caregivers, most are older. 1 in 10 of caregivers in this country are 75 years or older. And then we have the women who are giving care and the women who are needing care. And what I'm often preaching, people ask how well I do. I don't do so well myself, but I hope all of you are doing better at taking care of yourselves because we can't take care of everyone else. So now caregiving has gone from just a sociocultural concept to actually being the basis of research, being the basis of studies, being the basis of the science. What is the role of stress in health? How does stress and stress coming from caregiving as well as other factors affect the health of women? Well, then to just sort of bring this to a close, I've looked at this sort of in terms of lifespan, but then many like to look at the health of women in terms of leading causes of death. And these are obviously from the CDC data, but heart disease, cancer, and you notice stroke used to be 3, but now chronic obstructive pulmonary disease has moved up to 3. Alzheimer's is number 4, and look at diabetes that comes down. So those are for all women. If we look at the divisions on the basis of race and ethnicity, we can see some variations from, while heart disease is the most common for all women, and for white women and black women, cancer is the leading cause of death for Hispanic, Native American, Asian, Pacific Islanders. But you can still see that these same conditions, whether they're 1, 2, or 3, they're all important in the health of women. So we need to think about prevention, we need to think about treatment, we need to think about education, and which populations are at higher risk, and what are those contributors to higher risk? Because if you want to eliminate disparities, you've got to know what you're tackling so that you can be strategic in your planning, and that is important in going there. And if we look at different racial groups, while we see the top ones, these are the conditions that if you look the various groups that you could really summarize, and I'm not going to go through all of those. And then looking at threats to healthy aging, caregiving, wellness, staying active, mental health, which is so important, and looking at sexual health, which we don't talk about that much, but how important that is, not just for young girls, not just for adolescents, but also looking at older populations. And if some of you've heard some of the stories from nursing homes and those that run nursing homes, we know that these are issues, but that's healthy living, supposedly, for those who are at that stage and age. So we need to think about all of these issues in addition to drugs and alternative medicine when we're thinking about lifespan issues. And then we bring in the immigrant populations. We've now got more immigrant women, and they bring sometimes different, not only different conditions to be concerned about, but different cultural values, different family relationships, and how that affects their ability to get health care or to participate, for example, in clinical studies. And then looking at other undertreated, I'm calling them undertreated, under health service populations, like the poor, or those who are in inner city urban areas, or those who are in rural areas. How do we then make sure they're getting access to health services, and not just access, but actually being able to benefit from that. We've got to make efforts to improve health communication and health literacy. We've got to examine better, and I know many of you are doing this, and you'll probably talk about some effective ways to disseminate health information and better use some of the new social networks that can get this kind of information out, and with the focus on prevention. So we know that preventive behaviors can reduce the risk. And I want to just point out something that really concerns me quite a bit. We know that from research, and I've talked about research actually affecting practice patterns, that the IOM had a committee to look at clinical preventive services for women, using the latest in research on what really can make a difference in the health of women through preventive practices. And out of that came, as part of the ACA, recommendations for preventive services for women, which were then, based upon research, based upon the IM report, were then incorporated into healthcare as part of the ACA bill. These we're going to lose if the ACA is done away with. And my question is, what happens when we think about the lack of maternal health care? What happens when we don't have support for these kinds of screening services? And when we talk about access to health care, it's available, but how will it be available? To me, this is a good example of how research has moved forward. We know about the risk factors for heart disease. One of the things I get concerned about is that, and that some of them we can modify, others are not, getting the message out, with heart disease being the leading cause of death for most women. How do we get women to understand what they can do to protect themselves? But also, we don't want to make a guilt trip for women when they're thinking about it. And just one last example, and then I promise you I'm through. When we talk about diabetes, and we know that there are differences in diabetes prevalence, and we look at gestational diabetes, and we know that gestational diabetes occurs most often in women, especially from women of color, and that we've learned that what is important, talk about life continuum, that women who have developed gestational diabetes have a greater chance of developing type 2 diabetes after the pregnancy. You know, gestational diabetes usually goes away, and women are told to get a 6-month checkup, and the diabetes has gone away, and they think they're fine. But we've learned that actually they're more apt to later on, maybe years later, develop type 2 diabetes. But more importantly, the children of these gestational diabetes pregnancies are at greater risk of future obesity and type 2 diabetes. And that means that pediatricians need to know that they are born of GDM pregnancies, and that recommendation needs to be carried forward. To me, this is a great example of showing the continuum of conditions and how, you know, this is the in utero environment and how it can lead to adult disease and conditions. And that means we need to make sure that our healthcare system accommodates that. Well, you know about all of these, and I just mentioned precision medicine, which is sort of basing, and everybody's doing it because there's funding right now for precision medicine, so everybody's focusing in institutions on developing precision medicine initiative, but it's based on the genetic approach to the individual. But I'm hoping in that genetic approach to the individual, we don't forget the importance of ethical and social implications of this new approach, but also looking at all of the other factors that contribute to the development, the manifestations of genetic diseases, but also the whole health of the individual. So, how do we proceed? There's still a major challenge to overcome some of those political biases about what constitutes women's health. We need to continue to get the message out that while the reproductive system is important, women's health is more than just abortion and contraception. And I don't know how we get that point across more than we have. We keep trying. But we have to recognize and make sure that our leaders and our funders understand that women's health is more than just contraception and abortion, but reproductive health is important. That we look at some of these contributors to health inequities, that we need to be informed and make sure that women and their families are informed. And again, here I go with my latest soapbox issue dealing with the socio-political aspects of healthcare policies and practices. If we are going to have justice for all and human rights, remembering women's rights are human rights, that we really need to make sure that biased and uninformed politics don't affect what we do. So, efforts need to continue to provide advances, that means through research, in basic knowledge, prevention strategies. We need effective information dissemination. We need more effective cures and interventions if we're going to take care of these diseases that affect us. But always, with whatever we do, keeping in mind ethical principles and common sense approaches, because we can be all the smart information, but you got to have a good dose of common sense with it and how it's applied and what we do with it if we're going to bring about the kind of health equity that Dr. Warren always talks about and takes us forward with. And I know you're going to pull me off the stage, but this is my last slide. Thank you very much.
This next session is within the program is our plenary panel discussion. The title is Women's Health at the Intersection of Context, Inclusion, and Public Health Practice, a dialogue. So, the plenary discussion includes women representing racial and ethnic perspectives, women who live in rural areas, and scholars of religion and ethics. They will grapple with the larger question of how can we ensure an ethical practice of public health across multiple dimensions of women's lived experience. So we're very excited to hear the dialogue that's going to take place today. Moderating our dialogue is Dr. Dedan Dixon Diallo. She is a recognized visionary and advocate in the struggle for women's human rights and reproductive justice and the fight against HIV/AIDS on behalf of communities of women living with HIV, and those at risk for HIV and STIs. Dr. Diallo is founder and president of Sister Love, Inc., established in 1989, the first women's HIV/AIDS and reproductive justice organization in the southeastern United States. Dr. Diallo is a member of the board of directors at the National Women's Health Network, and she is a founding member of the 30 for 30 campaign for women in the National HIV/AIDS Strategy. She serves on the Fulton County HIV Advisory Board and is a co-chair for the Act Now End AIDS National Coalition. Dr. Diallo was recently appointed to the NIH National Institutes of Health Office on AIDS Research Advisory Council. She has received numerous awards and recognitions over the 32 years she has been working in HIV/AIDS and women's health and human rights. Please, a round of applause.
Thank you. Give me my hug for you. Thank you so much for that. Thank you. So, Sister Love is not an accidental name for the organization. As we get started, I just wanted to first say thank you for this opportunity. It is a privilege, and I know, and I'm going to say this very quickly as she walks out the door, it's been my privilege to have an opportunity to be in the room and to hear Dr. Penn's address, because I believe that in 1983, when I was a student at Spelman College, I became the youngest non-family member of the founding of the National Black Women's Health Project, which was the first ever Black Women's Health Conference held in this country at a national level on Black women's health issues in 1983, founded by Billy Avery. And Billy had the foresight even then to make sure that Dr. Penn was a part of that really critical and historical conversation. I'm a proud member of the National Women's Health Network, so in a lot of ways we have relationships with just about everybody who's on our panel today, and I'm excited to hear their thoughts and ideas on some of these challenging issues around the ethical practice in public health and in women's health across the lifespan. I also am really grateful for the question around community-based participatory research and community engagement, because that is something that we struggle with on a daily basis, as the fact that we are also a part of the Women's Interagency HIV study as the only community-based organization directly contracted into the study as a research partner. And I would be remiss to say that just as a person who is in her early 50s, that I am perimenopausal. I am not confused about what I just said. And, and that I think that mental pause is probably more of an accurate description of this experience. And so I ask early on forgiveness if I get a little few lapses as I go through meeting our new folks this morning. So we're just going to start out, and I'm going to take my seat in a moment, but this really is a dialogue and a discussion. So it is sort of the same way I run my radio show. It's a kitchen table conversation. We just left the kitchen table down there on the floor. And we're going to start with folks giving just a couple of minutes about yourself, and maybe inside those couple of minutes, a reflection or two about what we've talked about so far this morning or what we're having in our conversation. So I'm going to start immediately with my left, just to give you a sense of who's in the room. We have Professor Dr. Rosetta Ross, who is at Spelman College, and she'll tell you a little bit more about herself. And then we have, is that Maria sitting right next? Yes. And then we have Maria Lourdes Reyes, who was with the U.S. and Border Programs, Project Concern International. She's the director of those programs. And then we have Judy Monroe, President and CEO of the CDC Foundation. And at the end, we have Kathy Yep, Professor at Pitzer College of the Claremont Colleges. So can we just start with our first discussion question and then roll? All right. So I'm going to just start with our number one. According to the 2017 Proclamation for National Women's Health Week, Cindy would love it if I mistakenly said National Women's Health Network, women are more likely to be the primary caregivers for their families, caring for their children, spouses, partners, parents, caregiving, especially when a family member falls ill. And honestly, sometimes our employers, our coworkers, our church members, our friends. I tell you, my aunt, who is a retired family planning nurse, ran 5 family planning clinics for the Fulton County Department of Health and Wellness, been retired almost 20 years, and is still the nurse to the family, the community, the church, the neighborhood, and anybody else who happens to learn that she's a nurse and needs care. In doing so, many women tend to put their own health needs on the back burner. So, what are some of the primary challenges that impact our ability to address this behavioral tendency and other factors that negatively impact the health of women and girls across the United States? So, prioritizing our lives begins our conversation. And anyone who is ready to jump in, I guess we would start right here with Rosetta, introducing yourself, and then we'll go down the line and come to the question and discussion.
So again, my name is Rosetta Ross, and I teach religious studies at Spelman College. Prior to teaching at Spelman, I did teach in seminaries. My research focuses on religion and women's social justice activism, and particularly do I focus on women in the civil rights movement, African American women in the civil rights movement. Recently, I have been working with African and African diasporan women on ways that religion interact with the quality of life of women and girls across the lifespan, and there are both positive and negative factors, as you can imagine. So we're going to introduce ourselves and then respond.
Yes.
Okay.
Thank you. My name is Maria Lourdes Reyes, and I am the director for the United States and Border Programs for Project Concern International, a nonprofit organization. We are in 15 countries, Asia, Americas, and then Africa. So my work, I am a pathologist by training and practice, and like Dr. Pinn, but found myself truly looking at the communities that we serve. I was past president for the American Cancer Society for the state of California and was very involved in the cancer world. Also worked with the NIH, UC Irvine, being the research liaison for the communities on Pacific Islander cancer control in Guam, Samoa, United States, Tonga. But I found myself moving on to public health as a pathologist, really looking at the communities. So prior to going back to a master's in public health, I went through the business school to really understand what does that mean? Why do we have many programs and yet people don't come? And so really looking at where are the communities? What do we need to do? It really needs to be from the bottom up and not our usual top-down approach. So having moved on to public health then, I found myself at the beginning of life. Can you imagine? I'm a pathologist, really looking at the end of life. And then the program came about where I became the director for a Healthy Start program, a pregnancy program for HRSA. And so the beginning of life, and I said, wow, okay, public health is public health, medicine is medicine, I can do this. And so I really started with that and moved from that program to now a highest funded level with HRSA, looking at mentoring other states, Arizona, Texas, New Mexico, California, really looking at what are those disparities in pregnancy. But then, of course, I'm a pathologist, so it's a life course, a lifespan, and then have many programs now with chronic disease prevention. And just recently, working now with the Alzheimer's Association and hospice. So I feel like I have really looked at the entire spectrum of life and then all of the above. And truly, my personal mission statement, which is what I want to share, is that I am dedicated to the realization of human potential through servant leadership. And so as a servant leader, I am really at the bottom, serving the community, and that is how I wanted to live the rest of my life. We're not talking about age, because I think I'm the oldest on this panel, but anyhow, as a public servant leader. So thank you.
Thank you.
So I'm Judy Monroe. I love that mission statement, by the way. So I started my career as a family physician with the intent of practicing in an underserved community and had a National Service Corps commitment through HRSA that took me to Appalachia and practiced in rural America, where it really hit me hard, the issues facing women and rural women. And from there, my husband actually led me into academia. We went to Indiana University. I joined the faculty there. From there, went to St. Vincent Hospital, part of Ascension Health, to direct a residency program in family medicine, where I thought that would be what I would do in my career, and did a lot of women's health through the residency program and a lot of teaching, but then was called to be the state health officer in Indiana, and that was my journey from medicine to public health when I became a state health officer in 2005. And after 5 years of serving as state health officer and loving public health, then I was called here to CDC and became a deputy director under Dr. Tom Frieden and reported to him for 6 years. And now I'm with we established the Office of State, Tribal, Local, and Territorial Support, where I had an opportunity to work with all the health departments and communities across the nation. And now I'm with the CDC Foundation. Pleased to be in philanthropy.
Hi, good morning. I want to thank the offices of Women's Health and Minority Health Equity and the National Center for Bioethics and Healthcare for this interdisciplinary conversation, grassroots and grass tops. I think it's really innovative in that way, and it's an honor to be on the panel with you. So I am Kathy Yep, and my pronouns are she, her, hers. I'm a cisgender professor of ethnic studies, and I'm based in Southern California in Claremont Colleges. I'm also an associate dean of faculty looking at faculty development as well as diversity, equity, and inclusion. And I think my offering for today is thinking about the framings of research. So I'm pivoting away from just exclusion to inclusion, but to thinking about the power dynamics and positionalities in how do we ask questions, who's in the room, who's not in the room. I'm a fourth generation Chinese American. My family is all San Francisco Chinatown, and first generation college student, first generation faculty, and now administrator. And I think in terms of what I hope to bring to this conversation is ways that women and under-resourced populations have different forms of knowledges that can inform our decisions on a policy level, on a healthcare level.
Thank you. I'm already fascinated. How about you? Yes. So let's come back to the question, right? What are the primary challenges that impact our ability to address the specific behavioral tendency around women caring for so many others before we care for ourselves, and some of the other factors that negatively impact the health of women and girls across this country? Who wants to jump in with what your first reaction to that question was? Even when you first got it in your email, what did you go,
So oh, go ahead. Well, I'm going to jump in because this question hit hard for me. A year ago, Mother's Day weekend, my husband and I attended the wedding of a really great friend of ours, a pediatrician we'd known through the years that was actively practicing pediatrics in rural North Carolina. And we attended her son's wedding, and it was a wonderful weekend, just fascinating. Now, this friend of ours always took care of everybody before herself, her patients, her family, did a lot for her kids, and her answer to everything was always, but they're my kids, right? A month from the wedding, I went to the office one Monday morning. My husband called. He'd gotten word that she'd had a massive heart attack and had died, and she was in her mid-60s. This question hit hard because this is an example, my friend and colleague's death is an example of someone that did care for everybody, always put her own health on the back burner. We all fussed about her. We got after her. I personally got after her all the time about taking care of her own hypertension and issues. But it also is an example of it happens we're all vulnerable, and I think Dr. Penn said that. This is a pediatrician. She knew better. So she had the knowledge and still put her own health on the back burner. So I think part of it is we're fighting, in some ways, evolution. It's evolutionary. I mean, there is we want the gene pool to carry on, and so I think women over the eons have always cared for their families. We know mothers have always put themselves, or putting women in general, whether they're moms or not, putting the family first. But then there's culture, and culture eats strategy for lunch, as we know. And I think there's just such strong cultural, that this is what women do. We're the caregivers. And that's the narrative. I remember as a small child hearing the narrative of my grandmother and my mother. Quite frankly, in my case, my mother was like, well, it's a man's world. And my grandmother was saying she shouldn't be playing with microscopes and chemistry sets. She should plan to make toast for her husband someday, right? I mean, literally that was the narrative. And as a very young child, I didn't buy the story. But why was that? Why did I not buy the story, but how many women do buy the story, right? They buy the story all the time. So I think there's those kinds of issues. And then the other, Dr. Penn hit on this, health literacy, we're up against that. I saw that in rural America when I practiced. I would have women coming in with end-stage breast cancer, and their complaint was an earache. And they weren't even aware. I mean, it was just shocking. And so the health literacy and even knowing what was wrong with their bodies was really a powerful lesson for me when I first got to the county. And then, I think for women too, there's some self-esteem issues. We have things like depression that it's prevalent and may interfere with their health. And then trust of the medical profession, I would add as well. So I'll stop there.
Thank you.
You mentioned a few things in there, but I think as you'll find, we have different perspectives based on our backgrounds, theology, religion, rural equity, the ethicist the true ethicist among the group. And I was asked to really talk about the Hispanic population in many of my programs. I am Filipina, but I am 50% Hispanic, grandparent from Spain. But we have a lot of programs dealing with the Hispanic population. So what I'm going to share would be about the Hispanic population. And Dr. Pinn mentioned the social political aspects. That is really besetting many of our program participants. At the core of the primary challenge for this whole thing, at the core of ethics, is that values and beliefs of stakeholders. That was mentioned again and again. And so you mentioned culture, the beliefs. That is even not just among Hispanics, among all the ethnic groups in the country, the value and belief of the stakeholder, I think, is a primary challenge. But for the Hispanic population, the culture, the barriers of language and transportation, we have many women who are pregnant who don't even speak the language. And right there and then is a barrier to access. But then the how do we get them out of that? The mental wellness, the lack of mental wellness, not only for women, for girls, but I truly want to emphasize also for men, because we're not going to be able to have a holistic reach to our women and girls if we're not going to involve the fathers or the male partners in our efforts, but truly addressing that more comprehensive. When I talk about Hispanics along the border, the various issues, the lack of health insurance, the poverty level, which is at one of the highest rates in the country comparatively, depression, 42% of pregnant women have domestic violence and are abused. And then the colonias, I cannot even imagine. We just had a global leadership conference of all the countries that PCI is in, with the country directors being in Washington, D.C. these past 2 weeks. And they were saying, well, how do you look at the mother and child in the world? And I say, but take a look at the mother and child in the border areas of our communities in Arizona, Texas, New Mexico. They live in stables with the horse. They don't have water. They have to take their truck, if they have a truck, and get water to bring home. They still have an outhouse. So, we do in this country still have similar areas with many of the challenges that are in developing countries. And when you talk about the illegal immigration or the immigration per se, we won't even go to the politics of illegal immigration or immigration, but when you think about the undocumented population, a third of them have a child that is a U.S. citizen. So we need to really think about the impact on what Dr. Pinn said, social political aspects. And I think at the very core of what we're going to be doing in the communities, that needs to be at the core of that and the value and belief of the stakeholders.
Okay. Well, I actually want to begin with something that you mentioned as well, Judith, and that is the perception that women are caregivers. I think that we still need to talk about that a lot and how it ends up making such a difference in women's lives, and even the way our logic around women giving care is not consistent with the logic that sometimes privileges men. For example, one of the things that I thought about immediately was that there is an emotional element, but there's also a physical element, because giving care to some persons means lifting them, changing diapers, making sure they have proper nutrition, et cetera. And there's a lot of heavy labor, but that gets connected with women, although we often think about distinctions between men and women around the issue of physical strength, but that is not taken into consideration when we talk about giving care. One of the other things that I thought about immediately was the extent to which religion plays a role, and this is something I'm always talking with students about. Religion is interacting with almost everything, and it plays a role in the way we think about what women's responsibilities are, but even the notion of, and I'm going to push back a little bit on the idea of servant, because especially in Christianity, there is propagated the idea of being a servant, and even a suffering servant, that gets attached more to women, I think, than men, because of the idea of service being something that women do. So that there are theologies that are often being preached, and persons on the ground sharing those as well that interact with the way we think about women taking care of themselves, because the concept of love, also in Christianity, but I think there are ways that there are connections to this in other religious traditions. I know Christianity more, but the concept of love is also often thought of as not attending to the self, right? Giving to the other, right? So agape is understood as, in some theologians' perspectives, flowing everything out of yourself to the other person, and that there's something problematic in yourself as a Christian if you are attending to yourself. So our religion is as well. A couple of other things I wanted to note were the ways that religion interacts with making it difficult for women to build bridges, so that conceptions about who is a woman, especially in regard to queer and trans women, and the possibility of collaborating across the spectrum of women sometimes gets interrupted in terms of women attending to themselves because of the inability to push against theological perspectives about who actually is a woman. And then finally, for Black women, I think the legacy of having Black people, Black bodies having been chattel, it interacts with the conception of servant and women, because servant is also understood as person of color and as Black person, and I think that is in the psyche of all of us, actually, and something that we should talk about as we are pushing against this.
And as we go to Kathy, just as you were saying it, because my whole life, my whole world is talking about sex, and I love that, is the connection to the sexual identity, sexual health, sexual well-being, and sexuality of women in connection to servitude. And that whether it's through the historic horrors of slavery or even through the older context of marriage, why marriage existed, why we're in it, why we're not, and what happens in terms of those gender dynamics, it's all still related to this sense of service, servitude, and prioritizing others. So, and religion plays its own role in all of that.
And if I can just quickly add, I think that there is a deep connection to who is sex trafficked, and the idea of that being of service to persons who are the Johns.
There you go.
Yeah.
And I think
Just for you, Kathy, that was...
Well, and I think riffing off of that is this idea of trafficking and the social construct of servitude and sexualities. There's a normalization of it, and it becomes these categories like culture or gender, and then we use those categories in a normalized way in our research. So I think particularly for Asian American, and Southeast Asian women histories, and I can't speak for all of the populations, but I will offer what I know from my understanding of the literature is, we have our histories of being human trafficked, whether it's comfort women, Korean women with Japanese soldiers, et cetera. But often the research tends to look at it in terms of culture, Confucianism, and shame. And it doesn't go beyond that. It doesn't push back beyond that. And we don't look at historical traumas. We don't look at human trafficking. So I come to this conversation doing a lot of community-based research, particularly the action research, alongside immigrant and refugee elders. And the suicide rate for Asian women over the age of 65 is the highest of all women of all races for that age group. So a lot of the research might say it's because of obedience or because of shame factor or underutilization of mental health services is because of this flat notion of culture. But what I get to do is I get to learn from immigrant and refugee elder women at the library about what are the different social political dynamics of their health. I posted a prompt to some of the immigrant women, and they pushed back. Like, we don't want to talk about what you want to talk about. But so we ended up talking about their biographies and their stories, and through the biographies and the history timelines, we learned about women who had been trafficked, women who had experiences with domestic violence in multiple countries, split family labor and emotional care. We learned about occupational safety health, being seamstresses or working in the laundry. And through that process, we learned about access to health care because they're low wage. So part of it is they wrote their stories, and then those stories were the basis for grant writing. So I'm kind of looping back to thinking through conceptually how we need to have more complicated ideas of culture, and then also who tells us about those complicated ideas about culture. And perhaps from the populations we're trying to study can have a seat at the table to unpack through their stories.
I love that. Sister Love, we actually have a whole initiative called Everyone Has a Story. There's a whole video series, and it really is about the power of the lived experience to inform the programs, the service delivery, the policy work, the advocacy work. So thank you for that. And you actually started touching on the next two questions all in one, Kathy. So I'm going to just jump into that because we are going to move to you all at about 10:15. I'm just letting y'all know that now. That's my aim. That's not my promise. I mean 11:15. That's my aim, not my promise. But so I'm actually going to throw the two questions out together because I think you sort of already have provided where the synergy is in there a little bit. One is, what are some of the most ethical approaches or best practices in ethical approaches for modifying some of these patterns of behavior and other factors? And then how can women across that lifespan actually have a stronger voice in decisions affecting their health? I think those two things actually go well together, and that you started working on that a little bit, Kathy. So if you want to come in on some of that to continue, and then whoever else wants to jump in, that would be great.
So there's two ways. When I read this question, I was excited about it in two ways. And one is to think about the possibility of democratizing research processes and community knowledges. So we have Dorothy Smith and Patricia Hill Collins who talk about situated knowledges, and that's a valid form of evidence to have our data inform decisions. Again, I just get scolded by these aunties at the library, but it's such a good practice as a researcher, as an administrator, as a teacher. And they have multiple ways of sharing their understanding of what are social determinants of health and how do we upend them through autobiographical cookbooks. We've done poetry readings together and in multiple languages. So that's the one piece. And the other piece is, I am in higher education and I have the wonderful opportunity of training researchers. Most people who will go on to med school or critical public health, because I'm at a liberal arts school, so it's more on the bachelor side. And I think that's the big question for me, is really pushing my students to ask, what do they not know and what do they need to know? And what are their positionalities that shape, maybe they universalize what their situated knowledge is. So I think that's a question we have to ask ourselves as we enter any community or any room or any research project or any grant proposal, is what do I know and what do I not know, and how does that impact my sets of questions, and how does that impact, in what Dr. Warren said, is my ability to listen? Because ideally, from my perspective and training, as a researcher is someone who can listen deeply with humility and with compassion.
I'll pick up there, because the listening piece, that in the practice of medicine, a really key lesson is you start where the patient is at. I mean, that's the starting point, and that means you need to listen. You need to find out what their story is and understand that. And so I think, and I love what you do with your radio show, because I was going to say on this, I think some of the approaches are using the media very creatively and getting more voices out there. That power of story is so amazing in my own career, because I'm a public health practitioner. I was a clinician that actually reached to the media when I was in Appalachia, because I wanted to get these voices out and to be able to educate women. And the power of the media, that's how we reach the masses, right? And today, both with our social media, I think there's more creative ways that we can do that. Obviously, there's a dark side to the social media, and we've seen that with bullying and so forth, but we need to get the positive, I think, in our films. We should be influencing more of Hollywood and some of the films, what our songs, when we look at pop culture and so forth, what are the messages that are getting out that we can do? I wanted to touch on clinician bias, because I think we do need to recognize there's clinician bias, and we need to think about being more forceful in our education of clinicians, whether it's physicians, nurses, nurse practitioners, and pharmacists. You can go through the list, because I saw that a lot, especially in the role practice, the bias that individuals had. To the point, sadly, I was actually told when I went into Appalachia to practice that I was the first physician that had treated them like humans. And that was, I got to tell you, that hit me hard. But kind of bridging into the second question for the stronger voice, I'll just kind of end with this. When we talk about ethics, the tobacco industry has had some pretty unethical practices over the years. And when I was health officer in Indiana, they came out with a cigarette, the Camel No. 9, that was focused on women, particularly young women, and they would have parties inviting young women to come and have and give them free cigarettes along with doing their nails and their hair and giving them a martini No. 9 and so forth. This was all over the news back in the probably about 2007 or so. And so one of the things as a reaction to that, and I think fear is a really that's an emotion we've got to be very cautious with because it can be very damaging, right? But I think anger is something you need to harness and harness it productively. And so as a health officer that had cared for young women that had been addicted to tobacco and then saw the consequences of on the birth and low birth weight, I hit the ceiling when I heard about this. And so we started something in very short order called Influence Women's Health in Indiana. And what we did is we started by convening the most powerful women in the state to educate them about what was happening. And from there, we rippled through we had events throughout every county where women would come together and they would tell their stories and they would be able to have dialogue. And we helped facilitate that. And it was one of the most powerful things. I look back on it fondly, and when I go back to Indiana, even the First Lady, the governor's wife, always talks about what we did, and the legislator. So I think you've got to involve the top and the bottom, right? I mean, all across the spectrum of women's voices, we need to get angry and mobilize.
And I actually will pick up on involving the top and the bottom and make a connection to situated knowledge. When I thought about this question, I use a lot of images from the civil rights movement, and I thought of Fannie Lou Hamer testifying before the Credentials Committee of the Democratic Party in 1964. She was a very unlikely person to be doing that, but she did so and was able to do so because many people reached into where she was in a variety of ways and brought her voice into the conversation. So the situated knowledge is important, but there has to be, in terms of the ethics of attending to persons and overcoming some of the patterns, there has to be, from the side of persons who have power and access and influence, reaching in and making possible getting that situated knowledge. And it is not only about getting persons from one place to another, it also has to be about making sure that people who are talking with each other communicate with one another. And so issues of hospitality are important. Even translation may be important, and it may be that people have to learn each other's language. But getting situated knowledge, and there's a lot of work involved in that. And if I think of the Department of Health and Human Services and its agencies, for example, as the entities to whom the question of ethical approaches is directed, then I would ask, what are some ways that personnel can be directed toward getting situated knowledge from the most vulnerable persons who are the least likely to be a part of the conversations, because there's information there that needs to be gotten into the conversations. Yeah.
Yeah, social media might be changing that a little bit. I know that even one of my own physicians has their own Twitter handle and their own hashtag, and all you have to do is make a couple of the right comments, and you get reaction.
Yeah, but
of course,
I actually think there are populations who are not even interacting at that point where there's knowledge to be. But I agree, it is changing. Absolutely. Yes. Who's talking?
And as Maria comes in, I want to acknowledge your own acknowledgement of Sister Fannie Lou Hamer, and that, of course, for those who don't know, that's where we also get the standing moniker, I'm sick and tired of being sick and tired. And I think that a lot of, in addition to her political activism, a lot of her harnessed anger also comes from the fact that she's a survivor of what we know as the Mississippi appendectomy, which was forced sterilization on so many poor and black women in Mississippi and across the South during that time. All of these issues are, to go from forced sterilization to taking over the DNC are connected, but we don't have those conversations in public health spaces where policy and implementation hit the road in our lives. And I think that she's a perfect example of the voice, the questioning of the ethics, and the movement around making change happen. Yes.
And I'll follow through in what you just said, the policy and implementation connection. So, and then the voice. But are we truly listening? Dr. Warren's question. Are we truly listening? I mean, we go off and say we're doing community-based participatory research, but are we truly doing community-based participatory research? Is that voice really at the table to get that knowledge that we really need to do? I think we have come a long way, but we have so much more to do. And I wish I could do the Energizer Bunny to where we're all already in that Energizer Bunny and really to the end of these sci-fi movies. And I'm a movie buff. But talking about fast forward, I mean, we can't even be doing things fast enough. But when I looked at this question, I was really looking at, yes, Dr. Pin showed the biomedical model. But when I teach public health in health policy and law, I look at that socio-ecological model. At the center of that, and at the center of anything that we do, even in servant leadership, is that self, that person at the center of that. But are we really looking at all of those layers in truly looking at an approach? Perhaps we need to, when we look at an approach, look at every one of those layers, the self, the community, the organizations, the environment, and at the very core of that end cycle is policy and government. Are we really looking at the policy and implementation from the perspective of the voice? So when I take a look at this in addressing how do we get that voice from the women and girls and people, one of the things that I would like to really emphasize is that we need to address, first and foremost, I think, that mental wellness. It is now this year, the lack of is now the leading cause of disability in the world. And we put it aside. We don't have enough funds or resources allowing for improving mental wellness. But even then, at the very core of the programs that I have, I don't do any program, one, without the evaluation piece, and one without involving the people at the table to tell me how do I really want to reach them, and then their voices at the table. But looking at what are the things that I can do for people in the community to help improve their lives. And at the core of any program I have is life skills and mental wellness. That is the initial piece that I do before I even do chronic disease prevention. I look at teaching them how to budget, how to communicate, what is that financial literacy like, where are they in their education, what do they need, is it a language, where are they in elementary, are they going to, what is that path like to get to a high school education, because we know that is attached to better health outcomes. And so giving them the tools to get out of poverty, teaching them how to save. So those resiliency factors, resiliency tools is what I'd like to share and really emphasize. I was at the World Congress for Women's Mental Health in Dublin just 6 weeks ago. And even throughout the world, when we're looking at anything that we're doing all these approaches either on the treatment side, too late, kind of sometimes, but not enough on the prevention side. But even then, at the very core, is to really help people have that tool and factor as to being resilient. Otherwise, they're going to continue in this very bad cycle of falling back and not truly emerging as the power and the voice that we need. And until they get that self-esteem back, that little bit of, I am saving, I have this tool, I can go back to school, we're still not going to hear their voices. And even as much as we try to listen, we're not going to hear it because it's still going to be that whisper that's even beyond our decibel hearing age.
So we're going to move to the next question, I want to segue it with continuing the conversation on women and stronger voices. And so I have this next place of not only understanding the whole issue around resilience and the resilient factor, but as someone who works with women who are survivors of violence, gender-based violence, other mental health issues, particularly dealing with HIV and sexual relationships and risk patterns and all of that, is that what moves me and fascinates me the most about this work is the women who not only survive and are living the resilience, but then move from resilience to revolution, where they actually become a part of the movement for change, whether they're going to school to become nurses or public health practitioners or advocates or activists in the community on behalf of others with the same or similar stories and issues. So, you know, in January, there were hundreds and hundreds and hundreds of thousands of men and people who love, women and people who love us, who all showed up in Washington for whatever their issues were. And there was a myriad of issues that some was around anger, some was around fear, but people who had never found their voices before found their voices, even if for a day or for, you know, another hashtag or a pink, you know, knitted cap. So the question would be that in terms of the decisions that are made about women's individual health, what are some of the other ways that you're engaging those voices, not only on behalf of their own lives, but communities of women's health? What are some of the other ways that we're finding women find their voices?
I'll start. Thank you. I think one of the things that I like with HRSA and CDC, the Maternal and Child Health and the CDC, the ethnic approaches to community health, the REACH program to eliminate the disparities. One of the mandates, it's a mandate to actually have an infrastructure in the community called Community Action Network and Collective Impact. And the mandate is that the membership needs to at least 25% of the membership in any network or any group meeting that we have has to be from the community and participants. I think short of being mandated, we really must do it. But again, that implication of a mandate, you have to do it because it's a benchmark. You're being provided monies that are very hard-earned dollars that you really need to perform in these benchmarks. And sometimes that's the only way we're going to make the changes, is to make the mandates. Because we can talk all we want about community-based participatory approaches, but unless we mandate that the voices need to be at the table who are community members, who are participants, then we're not going to get that much ahead of us. So to me, we use that in the programs that we have, is that we follow the mandate with at least, be nice if it goes, the percentages go more than that, at least 25% of the membership needs to be from the participants themselves and from the community themselves. And I think that's when their voice is at the table.
Mm-hmm. So starting to talk about how we're changing our current practices, basically. Yeah, go ahead, Rosetta, and then we'll do Kathy.
Okay, one of the things that I've been working on recently is actually not only with the U.S., but a gathering of women in religions, plural, African and African diasporan women. And although the event, the consultation began in the academy, it is a consultation of practitioners and scholars. Mm-hmm. So the voices of women in religions, interacting with them not only from the perspective of what we do in scholarship, but also hearing their voices. And the context of religion or religions is an important context to hear women's voices across the social strata. And I think in addition to what we are doing, or what I'm doing in my own practice, I think it's an important place to consider, because the ritualizing that occurs in religious traditions, the words that people hear and the things that they do become a part of how they think about the world. So health agencies seeking places to interact with ritualizing persons' lives, I think is also an important possibility for expanding their voices, because I know that what people hear in churches, I hear them repeating, and if it's something different, they repeat it, and it becomes a part of their way of thinking, and I think that that can be done in regard to health and caring for the self as well.
Absolutely. Kathy?
And I appreciate you talking about the way things are echoed and resonated in different spaces. And in hearing from this panel, I was thinking about it's more than just info and content delivery. It's also about that process of transformation, right? And I think your example of resiliency is it's an assets-based approach, right? So how do we draw upon and water the seeds of leadership in different individuals? And that takes time, and that takes a commitment to a relationship. And we were talking about that earlier at the break. And I think that doesn't always fit in a grant cycle.
Right.
That doesn't always fit in a semester. And so I think that's that element of humility with that. So an example would be, I was in a discussion group with, again, the aunties at the library. And I had one prompt that was, what do people need to know about you that they don't know? And they spent about 30 minutes on what does that word need mean? Is it need like food? Is it need like shelter? Is it need like access to resources? And then we kind of got to the turn to needing that meaning in your humanization. What do people need to understand about you? And two of the younger-ish elder women said, I don't get paid for what I do, so I don't know if I have a voice in my home. And the elder woman said, no, you are worth something. And this is all in English, and then mixed with Chinese too. But they said, you are worth something. And they kept on repeating that over and over. And that ended up being the theme of their anthology. And I think that was that shift from info delivery to transformation, and then the opportunity to take a leadership role. And then now, over time, we can set up the infrastructure to deepen that, taking that phrase, you are worth something, and then adding on to that. And I think that's that piece of it's not just adding voices and not just providing information, but it's those spaces for transformation leadership.
So Judy, I'm gonna, because I know you're gonna respond to that, but I'm gonna go ahead and throw this next question in so we can grapple with it for 3 or 4 minutes. And that is, it's a perfect place to come and land with the CDC Foundation, is as we're talking about these current practices and these really granular stories of what it really looks like in the implementation space, in addition to how we're expanding, what are some of those resources needed to build capacity for addressing some of these ethical issues that impact practice, public health practice, research, or even policies? So some more things about the current landscape, and then what are some of the resources to actually implement some of these innovations?
Yeah, so on the last question, the only thing I did want to highlight, the clergy, we, in the public health practice, we used the churches a lot in Indiana to magnify the message that we were trying to get across, because it really makes a big difference. And then I think standardization too. Accreditation is an area that health departments now have accreditation, and there's opportunity in that. Because that gets modified and refined. Are we learning the right things? But when we think about resources, so money. Now that I've been at the foundation, I get that a lot. But it's people, processes, and technology are what we need, and that does take resources. But we can be creative about our resources too. I wanted to mention this. I love the story now of how in rural communities they're using like an Uber-like transportation, but they're doing it with community members because they've got the technology. It's like, so sometimes it's not actually additional resources or minimal resources can be done if we leverage the community at large. And then you give people even more involvement and purpose, and might help with some of these other issues, those that might not be involved. But I think that expertise is one of the things that's needed when we talk about resources. Expertise at the right time, at the right place important. I think case examples, I think people need, again, stories, and I love case-based examples to help bring things together, communication, as we all know. And then in all of this, we're talking about the analytical tools, and the analytical tools that are there for the practitioners. We got that the translation from research to practice, where the rubber meets the road, is so critical if we're going to really make a difference and have the implementation. So I think we need more tools in regards to that.
Anyone else? Anyone else?
I had something.
Go right ahead, Maria.
Sorry. Yeah, so I'm going to go basic on this question about resources. Since time about 25, 30 years ago, we looked at now what's called an evidence-based promotora model, which is the community health worker model.
Right.
That has now really expanded into all the ethnic groups. And there's 20 different names for community health workers, patient navigators, family navigators, whatever it is. I think at the core of resources, I want to just really emphasize the need for actually standardizing the community health worker model. And I'm one of those proponents of certification with the states. Not many states have looked at that. And the reason I say that is because it goes back to reimbursement and actually how do the people feel about the work that they do. I'm not discounting the community health worker work, that volunteer that goes and helps their family, the faith-based. But I still, I'm not an economist, but I'm very much into economic development, those resiliency tools. Give them something that makes them feel worthwhile, or that worth that, Kathy, you talked about in the aunties of the library with the aunties. But so the community health worker model is actually being used now in many communities. I attended the Communities Joined in Action conference in San Antonio 3 months ago, and many models in the cities and counties look at multi-sectoral approaches. The libraries, the police, the academic, the nonprofits, the people at the table, so that multi-sectoral approach, but at the core of that service delivery is the community health worker. And I think that needs to reach in all the different ethnic groups, even if we looked at the evidence-based initially on the Hispanic population, the evidence is there now that it is a valuable tool for improving lives through having someone from the community help provide that, bridge that gap. So I really want to emphasize that, because it's not enough that in 2016, only 48,000 community health workers were employed in all 50 states. That's not enough, because we need to reach those communities, and it's at the core of that service.
Thank you. I'm going to, we're going to come back at the very end for folks to have some closing comments, but I want to really appreciate the thoughtful responses and really critical issues put out on the floor. And I would echo the issue around the community health workers, which is a worldwide issue in terms of respect and inclusion of that field. But I also want to throw in that most community health workers come through community-based organizations, which is another part, another layer. I'd be remiss if I didn't support my sector. That is a whole nother layer where there's so much potential and so much opportunity for capacity building and system strengthening that we get left out, from the research world all the way to the implementation sciences. And so I just want to make sure that that community question writ large deserves and should be getting a lot more of the investments financially as well as infrastructurally as possible. So with a round of applause, thank the panel for our conversation thus far. So we're parting thoughts, and it can be in response if you like, but let's move through parting thoughts, 1 or 3 sentences or something like that. But I promised to keep us on time, and now I'm a little bit over, so.
Kind of in response, yes. I wanted to not directly answer the question, but to lift up again the idea of changing consciousness and ritualizing what people do. So I think the interactions with religious traditions and religious communities is important at any level. The creeds and confessions that are written and repeated that sometimes get crafted at the local level and sometimes at denominational or organizational level is another way to interact with what people are thinking. Just as the curriculum is developed, those creeds go out and are spread, and that is one thing that I wanted to lift up as a possibility. The other thing I wanted to affirm was relationship building and how important that is, and to underscore building relationships with what may be unlikely communities and contexts. And when I think about African American women and communities, I think the Black Lives Matter movement may be an untapped resource in regard to, well, I don't know, in regard to health care emphasis for Black women in particular, because the Black Lives Matter movement is very intentional about looking at all of Black life and being inclusive.
The interruption, did everybody see what Black Lives Matter did for Mother's Day weekend? Was everybody up on that? Raised money over the last month to bail out Black mothers from jails all over this country. Hundreds, if not thousands of women at the local level, local organizations raised the funds through the national messaging of Black Lives Matter, and they literally went and paid the bonds and bails of women mothers sitting in jails for fines for which they shouldn't be sitting in jail except for the fact they couldn't afford the bond. So if you gave money, there were women who were home on Mother's Day because of you. So thank you for that. Sorry about that. That's how they contextualize it and become relevant. That's how they become relevant.
Well, my parting words is I would like to thank everyone, CDC, Tuskegee, and each and every one of you for having the opportunity for me to be part of this panel. But deeply, I want to thank each and every one of you for the work that you do. And I guess I want to give you a call to action to dig deeper, dig wider in your commitment to the work that you do. And I'm just going to quote a male, George Bernard Shaw. And I feel this, and I truly think about this. The true joy in life is being used for a purpose recognized by yourself as a mighty one. So it comes from us, and then we give, but it comes from us. Yes. Thank you.
So I'll just end again. Thank you. Great to be part of the panel. I'd leave you with a thought or a question of what part of the problem do you own, and then what action can you take?
Yes.
That is so hard to follow, this panel. It's an honor to be part of this conversation. Maybe we should do a radio show together, something.
Thursdays at 6 p.m. Eastern Time, 89.3 FM, and on the web, we stream live.
So it's the parting words are to think about cultural context in more complex ways. I think situated knowledge is in the context of power dynamics and the relationality of that. And then lastly is, or not lastly, but is the unconscious bias. What do we carry in our situated knowledge? Situation knowledge isn't just about marginalized, under-resourced populations. It's about those in dominant positions of power. The quick plug is I had suggested some readings, and they're on the CDC website, and they're examples of the things that we have been talking about here, and there's my colleagues had suggested readings as well. The last thing I'd say is, and to your great question, mental wellness and mental illness is drawing from Thich Nhat Hanh, who is known as a theologian, but also his work during the Vietnam War in Vietnam was really public health and social work, and we must heal ourselves in order to heal others. So it's sort of that balance, and I think that's part of our task, our call, and our hope for everyone is that we have peace in ourselves, so that we have peace in others.
Wow. And I just want to thank this panel. Please give them a round of applause. Thank you for your comments and questions. And I just want to acknowledge and be grateful. Intersectionality is a word that we have been working with in the women's reproductive justice movement for 2 decades. And we want to acknowledge that intersectionality is a term that's coined and defined by none other than Professor Kimberly Crenshaw, a world-renowned human rights attorney. And I just want to acknowledge and thank the CDC because intersectionality has arrived at the Centers for Disease Control. Thank you.
So without further ado, we're going to ask Dr. LaBerge to come and introduce our closing plenary speaker.
So what a full and powerful and rich day that we've had. I'm just excited about everything that I've heard today. I was tapping my foot through all of the presentations, and I want to thank everybody who is still here, hanging in here to get us through the rest of our journey today. And I am very, very pleased and honored to introduce our closing keynote speaker, Dr. Melanie Nadeau. Melanie is an enrolled citizen of the Turtle Mountain Band of Chippewa in Belcourt, North Dakota. So she traveled all the way from North Dakota to be with us today. She graduated from both the Turtle Mountain Community High School and the Turtle Mountain Community College. She received her undergraduate degree in psychology from the University of North Dakota and a master's in public health and community health education with a concentration in health disparities from the University of Minnesota. She recently completed her PhD in epidemiology in the social behavioral track program at the University of Minnesota School of Public Health. She is a community engaged scholar and has worked 13 years on various research projects within the American Indian community. There's a lot more that I could say about Dr. Nadeau, but I want to end by saying that she has a wealth of experience working in community health education and research and is dedicated to improving the health and well-being of Native communities. She has been married for 24 years and has one daughter. And in her free time, I don't know when that is, right? She enjoys attending cultural events and hosting cookouts with her family. So please join me in welcoming Dr. Nadeau.
Thank you so much. And thank you for having me. I'm so excited to be here. It's been just great listening to everybody's thoughts. And before I get started, let's see, how do I bring this up here? Can I just escape out of this here? Okay. And okay. So before I get started, I just kind of want to reflect on the summaries that were given and just share some of my thoughts. Health literacy seems to be a big issue, in talking just from my community perspective. I try to relay to individuals that are working in community, that come into community, and that want to translate information back to the community, which is a step that unfortunately gets skipped a lot of times, and that's probably the most important step. But when you're looking at health literacy across the nation, you're going to see a second or third grade level of health literacy on average. So depending on what community you're working in, it could be a little higher or a little lower than that. And so it's really important that we're mindful of when we're translating these resources, who we're trying to target. Also, just thinking about cultural adaptation of current best practices, current interventions, current resources. We don't really necessarily need to recreate the wheel here. I mean, if we bring these resources to community, a lot of times, people sit down and put their own spin on it, and you'll end up with a great product. So I think that there's a lot of opportunity in that realm. Another thing is that with digital storytelling, that's something that's like hot on my in my arena right now. I think that when you're working with community members and having them share their stories, people relate to people that are like them. So when you're having someone share, or you're trying to change what's currently going on in the community, having people that the target audience can relate to is very important. And digital storytelling is a very powerful way to do that. And at the close of today, I'll share briefly a little digital story with you that I did on why I pursued public health. Community engagement. I mean, all of these things, I think we're all on the same page here. You know, these community engagement, I think we all understand the importance of that. But with the messaging, the social media messaging, I think that it's also equally important to counter the bad messages that are out there, to take the time to actually counter those publicly, because somebody said when I was in school working on my master's way back then that the impact of a bad message, it can take like 10 years just to remove that impact of that bad messaging. So, and how much of our efforts are actually going towards rebuttaling these things that are out there that aren't true. And I think too, you know, especially with American Indian data, the data is really weak right now. There's just really poor data out there for American Indians. You know, you can't say there's really good data out there. It's pretty bad, actually. And so, you know, but you use what you can. But I think that when we're presenting things, that we really need to stop and share with our audience the strengths and the limitations of that data that we're sharing, so that you can say, hey, this is really crappy data, but you know, I want you to be able to make an informed decision on whether or not you want to use this data. And I don't see that happening a lot, and I think that, you know, as educators, we need to take the time to share that with community. And the other thing that I didn't hear mentioned today, but I think that is a huge issue from my community perspective, is financial literacy. You know, I'm a first generation college student. I still don't know how to handle money. I come from a poor family, you know, so, and how does that impact one's health? How does that impact one's financial ability? How does that impact one's ability to stay in school? And, you know I'm not the only one. And so, you know, I think that when we're talking about health and improving the health of our communities, that, you know, I think something could come from increasing the financial literacy of our communities. Talking about community-based participatory research, I'm a trained community-based participatory research. I've done a couple projects in that arena. I think it's also important to, we talk about it as a approach, you know, or an approach. It's not an approach, there's a lot of approaches to community-based participatory research. There's so many people put their own spin on it. There's different ways of doing it. And so it really depends on whose approach you're following, or whose literature that you're using to drive your community-based approach, if you will. But at the end of the day, it should be a community-informed approach, right? And the other thing is that there's also a reality-based approach, and that is something that was created by John Poupart. He's from the American Indian community, and, you know, really focuses on the voice and storytelling of community. So that's another approach to be mindful of. And then, you know, the importance of engaging our communities in the evaluation and the creation of our assessment tools. So, you know, everybody wants to take this tool and say, hey, it's already been created, it's evidence-based, I don't have to do anything, I just got to go give it to my community. Wrong. That's not a good approach to do. And I'll just offer up a simple example. When looking at, I worked on a tobacco project for a number of years, and when looking at knowledge, you know, our knowledge question, are saying, you know, bringing in these cultural speakers around tobacco and saying, okay, now you know everything about tobacco from a cultural perspective, you know the positives and the healing of the medicine of tobacco. Now, are you going to turn around and share this with your community? And we got the same answers, no, I'm not going to, pre and post. Well, was that a knowledge issue? No, it was a cultural issue, because those people weren't the people that were recognized in the community as the ones that should be sharing that information. So you have to be, you know, mindful of those things, so it's not necessarily a question that's going to get at the answer that you're looking for. And then the opioid epidemic. I recently attended a harm reduction summit, and You know, it's an epidemic all over the place on our tribal lands as well. And, you know, one of the things that I think that we need to really get an understanding on, just from a personal perspective, is the policy differences and the intervention differences and what we can do as individuals, as, you know, because clinical people can, you know, help someone that's had an overdose, you know, but I can't. Well, at least in the state of North Dakota, but I can in the state of Minnesota. So like understanding the differences, you know, what are your limitations? What are you able to do depending on state to state, learning from state to state differences, but also looking at state to tribal differences and like how does that impact the work that we're doing at a policy level. And then to reflect on the students, one of the student posters, breast cancer, you know, risk factors, I actually did, that's what I just did my dissertation on. And, you know, as a community engaged scholar, I picked something in my community. I did a case control study in my community. There was over 400 people in my sample. I reviewed, you know, medical records, radiology records, all the way back. My first patient in my sample was born in 1901. But at the end of the day, what did I find out? I did this case control study as a graduate student. That's like unheard of. It's kind of crazy, you know, like what are you doing? But I learned a lot working with Indian Health Service. I learned a lot about you know, how I could use data, and I had a community-driven project. And at the end of the day, I found out that this breast cancer risk calculator that is available on the National Cancer Institute site that providers use to inform their patients of their risk of breast cancer isn't relevant in my community because those aren't the risk factors in my community. So I think that, you know, just not always assuming that those risk factors are the same in the communities that you're working in, and that things can change depending on where you're at. So that's kind of my reflection on all of your reflections. So I'll go ahead and get started. Today I'm just going to talk to you briefly. I'm going to try to make it quick about research considerations in tribal communities, sovereignty, ethics, and data sharing. And, you know, I always start out by talking about where I'm from, who my parents are. These are my parents. My mom is Shirley Black Eyes Bellegarde. My dad's Raphael Jack Nadu. Seems like on the Indian country there, you always end up with a nickname. Everybody goes by a different name. They're both from the Turtle Mountain Bana Chippewa Indians. It's one of many tribes in the United States. As of January 2012, there was actually 567 federally recognized tribes. And in 2010, there were 324 federally recognized American Indian reservations. So we're talking about a lot of different people here. And the thing that, you know, we need to stop and realize is that all these people are very different in culture, language, and like I try to tell people, American Indians represent the smallest population in the United States. We're about 2% right now, but we represent the biggest diversity on this continent. Here's a picture of my dad, and this is actually my favorite picture of my dad. Here he's sitting in front of a relocation sign, and relocation was an effort by the government to get natives off of their reservation out into mainstream society and to basically incorporate them into mainstream society. So because of relocation efforts, there's a lot of people that ended up being urban natives, urban Indian population, and there's different numbers depending on where you're at geographically, but about half of natives on average are in the urban community. And my dad, you know, he went out on this relocation program, and I mean, he was just, you know, he just got out of the Army. He went served in the Army, and then when he got home, he realized there was this program, so he went down to the Bureau of Indian Affairs, and he went out to California, and I'm like, wow. You know, he was 21 years old. He got a one-way ticket to California all the way from North Dakota. He didn't know where he was going, didn't know what he was going to, you know, what was at the other end. But, I mean, talk about brave, what a brave individual to do something like that. But, you know, there was nothing, you know, I was like, Dad, why did you do that? He's like, because there was nothing, you know, I didn't have anything at home. I didn't have anything to go home to. You know, so we're talking about poverty, education, employment, no jobs, we didn't have our tribal college back in that day, My dad said they lived way out in the bush, they didn't have no running water. They didn't have electricity. They went to town, they were lucky if they had a car that ran, so definitely dealing with some demographic challenges. And my parents, I never really got to see them together because they divorced when I was 2 years old, and my mother and my siblings and I actually stayed with my dad till I was 7, but unfortunately he ended up having a heart attack, so we had to go back to the reservation, and he had diabetes, and this is his mid-30s. He was, he was in his mid-30s, and so we had to go back to the reservation so he could have access to Indian Health Service, and so that changed everything. So this is the first time that I was like exposed to that level of poverty on the community level. I come from the city, and then all of a sudden I'm sitting there on the res, on the reservation, so it's kind of shocking. So, here's some, numbers for you. The one's a little dated, but I'm sure they're still pretty much the same. It's that coronary heart disease, Northern Plains, this is specific to the Northern Plains, we're more likely to report being diagnosed with coronary heart disease and to have a heart attack. And then the American Indian, Alaska Native adults are also twice as likely as whites to be diagnosed with diabetes. And women were 2.3 times more likely than non-Hispanic whites to die of diabetes. So a lot of disparities there. And we have, this is our Indian Health Service, and we do have a beautiful facility, but we do have challenges when we're talking about intervention and services and what's available in the community. And the dollars that are allocated per individual for Indian Health Service are really low. They're lower than what's allocated for federal prisoners. So, you're basically gonna get better health care if you go to prison than if you go to IHS. And it's not because people are doing a bad job, it's just that they're working under a very stressed, underfunded system. So what does that do to addressing issues? So here's a picture of me when I was in the 3rd grade, and they say that this is the age that kids really start thinking about what they want to be when they grow up. And I knew, like, when I was a kid, I'm like, I want to help my people, I want to make a difference, like, I want to do something about this, because I could see what was going on. And I grew up with all this stuff, so I have a very personal connection to what's, it's more than just a statistic, put it that way. And, here's some numbers for you. American Indians, Alaska Natives die at a higher rate, from chronic liver disease, unintentional injuries, assault, homicide, intentional self-harm, suicide, chronic lower respiratory diseases. We're also dealing with social challenges, violence, trauma, and loss. So looking at injuries, accidents, suicide, homicide, firearms. Then eventually I'd go on to graduate from high school, and I was a first-generation high school, and it's a little odd to put that in your bio, that you graduated from the Turtle Mountain Community High School, right? But I'm really proud of the fact that I graduated from a tribal college, and I'm really proud of the fact that I graduated from a tribal high school. And I think that's actually, for me, it ended up being a good thing. It kept me grounded to my community. And so as a first-generation college student, I had a lot of things that I'd end up having to face. And, just talking about educational disparities, the graduation rate, American Indians, you're looking at 82%, whites, you're looking at 94%. So there's a huge educational disparity, K through 12 for graduating. Then during my school years, I started a family. During my undergraduate school years, I started a family. And, unfortunately, one of the things, and I'm not the only one, but, with students that come from communities that are impacted by a lot of stress socially, you have to deal with that. Like, there's a lot of death. I've been going to funerals since I can remember, and it's the life that I live. In fact, my brother-in-law passed away last week, so it's just like, then 2 days later I'm graduating, you know what I mean? So it's like this, it's like you're always operating in crisis mode, it almost becomes second nature. But this was the one that impacted me the most. My mother, she passed away from cancer. I took care of her till the day she passed. And this is at the point when my life took a totally different direction. I was like, do I really want to be a doctor, a medical doctor? And this is where I changed my mind and ended up going into public health. So, some stats for you. Death rate for malignant cancers for American Indian, Alaska Native persons is 338 per 100,000 compared to 223.4 for whites. Here's our college. So I was very fortunate when I moved back to the reservation to regain financial stability after my mom passed, that I had a tribal college here to attend. And this is actually where I discovered my first mentor. I ended up taking a genetics class with Dr. Lyle Best, and he he retired as a clinician medical doctor in my community at the Indian Health Service, and he was actually the medical director at one point. And he's non-native, but he was very vested in our community, and he actually got a grant to conduct a genetics and preeclampsia study with the women in our community. And it was really good because it wasn't community-based participatory research because the community did not pick the topic, So now we're at the center that I run, we're moving to the point to where we're trying to work with tribes to create agendas, health agenda, what do they want to address? So research agendas, and so that you can match the researcher with the research agenda so that it's a more meaningful partnership instead of the researcher coming in and say, hey, I want to do this, and it doesn't make sense to the community. So, but aside from the community not picking the topic, a lot of the components of his project had community-based participatory research characteristics. And just to name a few is building the infrastructure at the college so that we could do genetic research, working with elders in the community, translating information at multiple levels of the community. So he did a lot of things like that. So, and here's some statistics that I wanted to share. And, one of the things, if you look at our community graduation rates compared to national rates, we're not doing as well, right? But then when you break it down, and this is specific to my community, it could be totally different for another Native community, but for my community, what we're seeing is that our men are not doing very well. So when you start breaking those statistics out, our men are sicker, our men are, not graduating at the higher rate. And so when we talk about wellness of women and children, we need our men. We need our men to be well. We need our men to be brought to the table. And I hear that a lot in the community, with the community efforts that we work visiting with the tribes. So, but the tribal college is where I started my research journey. And the first thing I heard is, we've been researched to death. And I'm sure everyone's heard that one before. And some of the, concerns are that the results aren't interpreted in a language or formats that are appropriate, and we talked about that. Coming into community, there's a lot of work. I sit on the Turtle Mountain Band of Chippewa Indians Research Review Board, and in that role, people will come and propose research to us, and it's like, have you talked to anybody in the community? Have you brought letters of support? You have a great idea, but is it feasible? Oh, we didn't do that. Well, okay. Somebody goes over to mental health, and mental health, oh no, we can't, we're working in crisis mode here. We barely have enough staff to see our patients, much less do a project on the side. So, and that doesn't always happen, but it's just being mindful of, you know, what's currently going on in the community, history, demographics, the history of research in a particular community, cultural, traditional versus non-traditional, the etiquette. You know, just encouraging the community involvement, be prepared for possible community consent. With our board, we actually review everything. So even if it's not research, we review it. We review everything coming into the community, because we're at a point to where, and maybe that won't always be so, but we're at a point to where it's like, how do you sit there and make an informed decision whether or not something's research or not if you didn't review it? And then just raising that awareness about what's going on. Hiring, you know, people from the community to actually do the work, respecting community protocols, and, you know, just really just taking a minute to say, you know, community considerations are not always the same as individual academic research considerations. They're different. So one example that I could give is up in Alaska. There were so many communities that were selected. It was a randomized clinical trial, from my understanding. I really don't know the work that well, just so forgive me for that. But so they selected so many American Indian communities to get the TB vaccine that they were testing, and they selected so many to not get it. And my community was a control group. Well, I ran into a lady in Alaska. She was a descendant from someone from her community, and that they actually got the vaccine. So, but what went wrong there? Well, what went wrong is the vaccine was very successful, but then it wasn't turned around and administered community-wide. So then the community was pissed off. See, so did the researchers do anything wrong from their standpoint? No, not necessarily, because they were operating from an individual academic perspective, you know, but from a community perspective, that was wrong. So, you know, just taking the time to realize that those things don't always align, and then when you're working on a community level, that doesn't, you know, that those are things that need to be taken into consideration. Also, you know, just really taking the time to say, did we get it right with publications, presentations, results? Everything that I do goes through my community before I publicly talk about it. So it's just a good way to be anyway. And then, you know, just talking about from my standpoint as a student, as a doctoral student, you know, my classmates had to get an approval from the Institutional Review Board at the University of Minnesota. Well, since I was working with my tribe, I had to get approval from the University of Minnesota Institutional Review Board. I had to get an approval from the Aberdeen Area Indian Health Service Institutional Review Board, which could have determined that I would have had to get a national one, but they said that I didn't have to, so that was good. I didn't have to get that extra one. I had to get approval from the Turtle Mountain Band of Chippewa Research Review Board. I had to get a resolution passed with my tribe, and I had to get a letter of accommodation from the CEO of the Indian Health Service. So it's kind of different when you're working at that level. But it's good. It's good. I think it's important to have those levels of approval as well. And, you know, just understanding that it's important to build these meaningful relationships, being culturally competent. And this is like, this goes for like American Indian to American Indian even. Like, you know, I might be competent with my own people, but that doesn't mean I'm competent with the tribe down south. So if I'm working in that community, I have, you know, if I want to work in a good way, then I want to attend anything that I'm welcome to, you know, so that I can get to understand the ceremonies, the community activities, the service activities, the volunteer opportunities, everyday activities that are occurring in that community as well. And you know, just really trusting the community in that they know what they need and they know how to get it done and they know what it takes to make their communities healthy. So when producing projects, it takes a lot of time. I mean, products for American Indian tribal audiences, it takes a lot of time. And I'll use one example. There's an organization that approached my center and they said, we want to make sure that our materials are culturally competent. I'm like, okay. And so they brought them in, and my team, we do everything on a team-based approach. And so we make decisions as a consensus, because that's a traditional way of doing that in our region. And so we don't move forward on anything unless we all agree. And so when reviewing these materials, we were, you know, kind of laughing because it was not one of those pictures of those individuals on these materials, like, look, they weren't from our area. They were like from different tribes, you know what I mean? And it's like, no, 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 no. So then they went back to the drawing board and they came back again. And I think the second rendition was worse than the first one, you know? So I was like, oh my gosh. So anyway, so now they're gonna have a campaign to do some pictures from people from our communities to include in their cancer resources. So like, yes, that's the way it should be. So, incorporating the local knowledge and traditional knowledge is very important. And I'm not sure how I'm doing on time here, but anybody have idea how much time I have left? 5 minutes? Okay. So, yeah, just taking the time to do things right. And then we talked about community-based participatory research. So, you know, just talking, and I touched on some of these things already, research in American Indian communities. So a lot of, you know, for my community, our board's only been, you know, in existence for a couple of years now, you know, so we're learning a lot through the process of having our board, and just making sure that that we're regulating the projects that are coming in, reviewing everything, using a checklist to make sure that that everything's in compliance, passing resolutions with the tribe, that our team possesses the professional qualifications that are required. You know, and we do that because we video conference, so we're able to meet. So it's not like people have to be in community, you know. So just taking advantage of technology in order to make these things happen, especially in rural communities, is a very good way to go. Tribal possession of the data is very important to prevent misuse. And I haven't come across where they said, no, you can't use it. It's just mainly just being a good, you know, being, just informing the community what you're doing, and you actually end up getting some really good advice on how to move forward, so it works out pretty good. So, yeah, and you know, just from American Indian community perspective, just making sure that you know who the researcher is, what research they've done, why do they want to do research in your community. You know, we have people approaching us from all the way across the country. Why? Why do you want to do research? And it might be a very good reason, but why do you want to come all the way over here and do research right here? And does your reason, you know, make sense for our community, and is it going to benefit our community? So, and a lot of these are reciprocal in nature, but you know, just staying informed basically of the research and making sure that the researcher is reporting back and reporting to community. Not only reporting back, reporting out to community and translating that information at multiple levels so that it's actually useful to the community, and they can take that information and use it in reports, use it in grant writing, etc., or use it for social, you know, to change social norms. And then, you know, asking them, do you want to be identified in this publication? Some tribes don't want to be. Some tribes say, yeah, of course, we want to be recognized for the work that we contribute to. So, you know, that's another consideration. So in conclusion, the best way for American Indians to ensure that they're not harmed by and benefit to the greatest extent from the research is to be involved throughout. And I'd say this is true for any community. And this is a picture of our elders group. They actually overseen our project at the tribal college, and it was really, really good. And you know, I think the thing that probably stayed home with me the most is that once they were done, they went in the lab, they learned how to pipette and do genetic analysis. They listened to our spiel, all that good stuff. But then they turned around and they said, okay, we want you to talk to us about cancer. We want you to talk to us about diabetes. We want you to we want you to explain to us what Fragile X syndrome means. So realizing that the work that you do is not only about you, you become a resource to those individuals in the community, and that you're expected to step up and fill that role, even though it might not even have anything to do with the work that you're doing. And then I'm just going to finish by playing this little video for you that I created on why I chose public health career. Here's a picture of me in the 3rd grade. At this age, I started thinking about what I wanted to be when I grew up. This is a picture of my Uncle Benny, Dad, Mom, and Uncle James. My Uncle Benny died from an unintentional injury, my mom from cancer, and my dad lives with diabetes. Both of my grandparents passed away from cancer. My Uncle Baby and his daughter Ivy were shot and killed by the same bullet. My Uncle Edward passed away from cancer. Eventually, I would go on to college as a first-generation college student. Experiencing all of this loss motivated me to pursue a health career. My Uncle Bernard passed away from an aneurysm. My cousin, Bernard Jr., passed away from cancer. My stepfather passed away from an unknown cause. My Uncle Francis died of asphyxiation. Right before I graduated with my master's degree in public health, my father had a toe, partial foot, and a below-the-knee amputation due to his diabetes. I'm happy to report that it's been 4 years since his amputation. His first prosthetic leg says a lot about his personality. It has lightning bolts on it. The fall of 2010, I entered into the PhD in epidemiology program in social behavioral health. Thank you.
So let's give Sean a round of applause. Yeah, I just want to say in conclusion of a wonderful day, we started out at the beginning of this year to pull together this forum, and I couldn't be more pleased with how the day has turned out. We have been challenged on many fronts over the last several months, but we came in this morning with smiles on our faces because we saw all of you here. And so I just want to thank you. I want to thank all of our speakers, our facilitators, everybody who participated in today's program. And I hope that you will carry what you heard today both with you in your heart and in your minds, and consider it seeds planted that we are looking to water and to see a great harvest. So thank you for being here.
The thanks go far and wide from my context, but start with Dr. LaBerge and Dr. Tucker. I think you need to know that the coming together of these two issues in times such as these was phenomenal. And they made a commitment to make it happen, and it's happened. So I want to publicly thank both of them. And the partnership, and I'm intentional about talking about the difference between relationship and partnership. The partnership that we are enjoying and growing with the Centers for Disease Control and Prevention it's a work in progress. that requires attention every day. And Joe Valentine gives that attention every day, and I want to thank her as well. And then you've heard the cliche, the media is the message. And there's been one message bearer for the National Center for Bioethics and Research in Healthcare, because so much of what you hear is not true. So much of what you see is not true. So much of what you've heard is just wrong. And I want to thank Dr. Joan Harrell for assuring that the message that you're hearing about these events is true, is correct, and is consistent. Dr. Harrell, thank you so very much. And I'm not going to take any more time thanking folk. I just want to thank y'all. But the issue for me is about women, not mother, grandmother, wife, daughter, granddaughter, aunt, uncle, not uncle. I got caught up. But it's not about the social role of women. You know, I don't know the right word, so I won't use it. I know the right word, I won't use it, but maternal and child health. I've been working in public health for many years, and I've shudder when I hear maternal and child health, as if women are connected to mothers only. And we were intentional about listening, as I started off talking this morning, and this forum was about women and girls, not their social role, just to be a woman and to be a girl is what this forum was about for her whole life. And so I want to thank you all for listening and hearing, I hope, about women. And the office of, let me get the office right, public health ethics is at CDC is really important. It's a courageous step to say that public health ethics is different than bioethics. It's an important paradigm shift that's still in progress. And I think both the leadership in that office is really Drew Barrett, Dr. Orton, have done an outstanding job in making a distinct difference, not good or bad, but different. And as public health ethics grows, you'll learn more and more about that difference and appreciate it, I hope. So I want to thank you, too, particularly for your courage to bring this new paradigm into fruition. And last and most importantly, from my context, in the historical context, I want to thank Booker T. Washington for his courage and wisdom and vision to say that we all ain't the same, and that's okay, but we're all equally as important, and that's okay. And his courage to say something then that many times we don't have the courage to say now is that we need to target those who are in greatest need with all of our resources. He's done that, and you see the results of that. And again, Minority Health Month started with Booker T. Washington. And I want to thank you all for having the courage to saying that loud and clear for those who didn't know. And now they don't have to even say they didn't know. All they can say now is Minority Health Month started with Booker T. Washington, Negro Health Week. So as we close, and lastly, you know, we said 2 years ago, this is an annual event. And unfortunately, we have so many vulnerable populations, so we don't have a problem with figuring out who to target because their vulnerable populations continue to grow. So I look forward to the day when we won't have to talk about public health ethics and target populations because the ethical issues will be applicable to everybody. And They won't be equal, they'll be equitable. And I hope now you know the difference. Thank you so much, and we'll see you this time or soon next year.